down. Thank you so much. All right, once again, a very warm welcome to each and every one of you to the Future Healthcare Summit 2026. Well, ladies and gentlemen, I would like to tell you about the booths that we have arranged for you all. They are a preview of everything that we're about to discuss today. Our team is here to take you through the innovations that are on display. So please have a look on them if you get a chance. Our team is here to assist you, so please engage with them and get a chance to take a look at the innovations that are on display today. Also, I would like to take a moment to all those who are joining us live on ETHealthWorld YouTube channel. Thank you so much for being a part of this important discussions today. That means a lot. Well, ladies and gentlemen, I would like to take you through the booths that we have displayed. We have several booths here. First of all, I would like to tell you that these are really incredible innovations that we have put on display. You know, really important for healthcare at this point where AI is such at the growing stage, and you know, we have to use it in the right way for our people. So, ladies and gentlemen, let me take you through what is displayed here for today. So we have this ultrasound station that proud to showcase the future of healthcare and Philips ultrasound, where cutting-edge AI technology meets the pride of being made right here in India. Well, this powerful combination of local manufacturing and global intelligence is designed to bring unprecedented diagnostic confidence to clinicians nationwide. Then we have the IGT station, where we step into the future of image-guided surgery at our Philips booth. See how Azurian and Zenitian combined with AI-enabled workflows are helping clinicians perform procedures with greater speed, precision, and confidence. Then we have the Heartprint, where you experience the Heartprint and AI-powered solutions that helps identify early signs of physical and psychological risk. In under 3 minutes, you use your mobile phone camera to check your heart rate, strength, fuel, and mileage, and experience it yourself today. Then we have the Smart Speed Philips AI, where you get a breakthrough of MRI technology that uses AI to make MRI scans faster while maintaining high-quality images, being clinicians make confident decisions and improving the patient's experiences. Well, ladies and gentlemen, we'll be starting in next 5 minutes or so, and I request once again to all of you to please have a look at the booths we have arranged for you all. Our team is here and you can engage with them. They'll take you through the innovations are on display. Well, till then, I would like to ask a few questions about AI to all my audience who's present here right now. So I want to ask, how can you describe AI in one word if you can? Like, what does AI means to us, to you? So I would like to know, how do you feel about AI? How can you make it into just a single word? How impactful or how important it is in our lives today? So anyone would like to tell me? And I request our team to please pass on the mic. Can we have the cordless mic, please? So I would like to ask if anyone can share how do they feel about AI. You just have to put it into one word if you can.
I can try.
Yes, sir, please.
Just to let you know, I'm Anjan Bose. I'm the former MD of Philips India.
Okay.
Much before Bharat. So one word is tough. One word would be mysterious at this moment. I'm a practicing AI guy.
Yes.
So I see a lot of unanswered questions. So my one word would be mysterious at this moment.
Mysterious. Well, I think that we all agree. We all agree? I think that deserves a big round of applause, ladies and gentlemen. Let's do that. Thank you so much, sir. And someone else would like to try? How can you describe AI in one word? We agree that it's mysterious, but what else?
AI as a neighbor. So if you understand it, you can be friends. If you don't, it can be your enemy. You have to learn to live with it and coexist with it.
All right. Thank you so much, sir. But I would request you to say that once again. Can we have the mic again?
So,
Yes, sir.
hi, my name is Rohit, and
Hello, sir.
the way I define AI is your neighbor. So if you understand it well, it can be your friend, it can be your enemy. If you don't understand it well, you have to learn to coexist with it, learn to live with it,
Yes.
and life becomes smoother if you have good neighbors. So that's AI.
Wonderful. Can we have a round of applause once again? Thank you so much, sir. So now, anyone else would like to try, would like to share their thoughts about AI? Or I want to know, in your opinion, what one thing that AI can do to better the healthcare? That's the main discussion that we're going to have today. But according to you, like, what do you feel that AI has done it for the healthcare sector? Yes,
I don't
sir.
want to hog much of the thing, but you are you're asking very tempting questions which tempts answer. So I would say, AI, the expectation is bring in much more efficiency in the
Yes.
overall healthcare delivery, and also without compromising on patient safety and quality. I would like to highlight the second part. I think Philips has always gone for patient safety, quality. Patient has been the ultimate for Philips.
Yes.
So I think in the excitement of what all AI can do technology, we should not lose sight of that ultimately is the patient that matters. And I think AI can do a lot of that if harnessed properly. Like the gentleman said about neighbor, that's a very controversial word, but yeah, I mean, if you harness properly, it can bring in great efficiency in healthcare delivery and good for patient care, quality and safety.
Definitely, sir. Thank you so much. Ladies and gentlemen, a big round of applause once again. Thank you, sir. So anyone else would like to share their thoughts on AI? How do you describe AI in one word, or how do you think AI can help in healthcare sector?
If it's one word, for me, the potential or the promise that AI holds is about access to healthcare.
Yeah. I think that's a great one. Ladies and gentlemen, a huge round of applause. Come on. Anyone else on the second tables? Yeah, we have one.
Yeah.
Yes,
So I
sir.
think AI is a big enabler. I mean, when you talk about how it is changing healthcare, it is enabling the patients to be more involved in their own care. So that is what I believe AI is going to bring in.
Yes, sir. Great thought. Ladies and gentlemen, once again, a big round of applause. Let's celebrate each other. Come on. Let's celebrate how we think. Anyone else would like to share their thoughts on how do you think AI has helped in the healthcare sector? Or how do you describe AI in one word? Do we have someone who would like to share the thoughts? All right, thank you so much, ladies and gentlemen, and a special thanks to all those who have participated in this activity and shared their thoughts with all of us. Thank you so much, and I would like to take a moment once again to thank all the viewers who have joined us on the ETHealthWorld YouTube channel for joining us to this important and exciting conversation that we're going to have today. Thank you so much once again for joining us from wherever you are watching us. Thank you so much. And please be with us as we'll be having such important conversations ahead. So according to the agenda that we have some presentations ahead with some panel discussions where we'll be describing the trust before scale, building responsible AI for India's health ecosystem. And the next panel that we'll be having, the new economics of healthcare, where we discuss, can AI improve outcomes while reducing burnout and improving efficiencies? Well, ladies and gentlemen, you also have the agenda copy on your tables right now, so please have a look and go through. So we'll be starting now, ladies and gentlemen. So I request everyone to please settle down once again, and we'll be starting now. So ladies and gentlemen, good morning. Good morning. All right. I think you all agree with me. It's a very important and exciting day that we're looking for. So why don't we start with a little more energy? And I think we'll be doing that. So, ladies and gentlemen, once again, good morning. Fantastic. Well, that was the energy we're looking for. You know, usually I go ahead with the questions like, how do you feel today, how we're doing today? But you all have actually passed the vibe check. So I think we are good to go now. So, ladies and gentlemen, my name is Dr. Azra Khan, and trust me when I say this, it is such an honor and absolute pleasure to be standing in front of you all and welcome you all to the Future Healthcare Summit 2026, Shaping the Future of AI in Healthcare, presented by Philips in association with the Economic Times ETHealthWorld. And a very warm welcome to all of you who are joining live on the ETHealthWorld YouTube channel. Thank you so much for being a part of this important conversations that we're going to have today. Well, it is such a wonderful feeling to see such eminent people here with us today. Leaders from government and healthcare sector, clinicians, healthcare institutions, policymakers, technology, and industry, all coming together to answer the question that is becoming increasingly important. That is, how can we harness the power of AI to deliver better care for more people, responsibly, equitably, and at a scale? Well, AI is no longer simply a conversation about the future of healthcare. It is already transforming care today, and the opportunity before us is to understand how can we scale that impact responsibly. Well, today's conversations will take a look at what that means to Indian context, for clinicians, for healthcare systems, and most importantly, the patients. In fact, the Future Health Index 2026 India report gives us a powerful indication of that optimism, bringing some fascinating perspectives on this ever-evolving healthcare landscape, which we will hear more about later this morning. So we have a very exciting morning ahead of us. Over the next few hours, we'll be hearing from some of the country's leading voices across government, healthcare, industry, as we explore the opportunities, responsibilities, and the real-world impact of AI in healthcare. And with that, ladies and gentlemen, it is my absolute honor to welcome and invite Mr. Bharat Shesha, Managing Director, Philips Indian Subcontinent, onto the stage for the welcome address and to set the context for today's conversation. Ladies and gentlemen, a big round of applause for Mr. Bharat Shesha.
So AI is going to transform healthcare landscape in India. I mean it. And if you're skeptical about this statement, if you stay on with us for the next few hours, you will be convinced too. Welcome, all of you, to the Future Healthcare Summit 2026. A very warm welcome to the distinguished panelists, our customer partners, stakeholders, and my wonderful colleagues. A very, very special welcome to Dr. Sunil Kumar Banwal, CEO of National Health Authority. Thank you for coming, sir. There is no one more appropriate than him to come today here, not simply just because the responsibility and the scale of responsibility that he has as the CEO of NHA, but also because he's pushing us and he's asking the questions to all companies and stakeholders, how can you make this relevant for India? And with his background in law, in policy administration, in engineering, and being a topper in UPSC, I think there is no one better than him to come and share his insights to us today. And I'm sure he will give us some inspiring thoughts to take forward. Thank you, sir, for being here today. It's our pleasure. At a very basic level, the Indian healthcare challenge is about two things: quantity and quality. Better care, which is the quality part, for more people, which is the quantity part. And when we talk about AI today, I think every boardroom, every hospital, every doctor, and even many patients today say AI in healthcare. But for me, this is not a technological topic. It's a human topic. It is about this young doctor in a district hospital somewhere in the middle of India who wants to give the best care to the patient without having the support system of specialists around them. It is about the nurse who spends as much time looking at paperwork and doing administrative tasks as he or she does with a patient. And it is about this elderly couple living in a tier 3 town who need to travel to access the care that they deserve. These are not technological questions. These are human questions. And as I travel around the country and I meet with healthcare leaders, professionals, doctors, patients, the discussions are varied, but the aspirations are very similar. So the question is, how can I release more time of my clinicians to do what they want to do, which is to be with patients? How can I make sure my patients get the best outcomes that they deserve? And how can I upskill, reskill, and continue to keep ahead of the technology curve as clinicians? Again, these are not technological questions, these are leadership questions. And if AI cannot answer the human question or the leadership questions, then we're doing something wrong with this tool. And that brings me to where we are here in India. Indian healthcare system has evolved over many years into clusters. There are concentrated nodes of clinical expertise, excellence, infrastructure. And patients need to come to these nodes. And we have a unique opportunity here in India today, which is to democratize this healthcare access at a population scale using tools like AI. And if we do this in India, we would be the first country in the world to do this. And that is a historical, unique opportunity that we all have. And to do this, AI cannot replace a clinician. What AI can do is to amplify a clinician, amplify their presence, amplify their capabilities, amplify their capacities. In the human example, I said a young doctor in the heart of India in a district hospital getting access to the best medical advice they can using AI, using remote access, talking to the specialist in a city. Those are transformative changes that AI can bring to healthcare in India. Again, the key is to always keep, and I always say it's not human in the loop in healthcare, it's human in the lead. And for all of these transformative things to happen, there is one fundamental foundational thing that needs to be there. And it's something that we can't touch or see, but we can feel, and that is trust. Without trust, technology cannot scale, especially a technology like AI will not scale. And there, I want to really compliment Dr. Banwal and the government, because the foresight with which they have released the SAHI policy, the BOTH policy, and the latest guidance on AI and medtech devices by the CDSCO, all these are steps in that direction of building trust. And I was just talking to Dr. Banwal at the speed at which we are doing it now is unheralded. And he had a very sage response. He says, AI is moving so fast, we need to move as fast as AI. That drive, that desire, and that movement towards making these policies as guardrails, as guidance for all stakeholders to follow, to embody, and to deploy is what is going to make it transformational in India. Because when we impact healthcare, we don't just touch on the health of an individual, we impact the future of the nation. I want to welcome again all of you. I hope today, over the course of the panel discussions, listening to Dr. Banwal's thoughts and insights, and other discussions you will have, you leave convinced that we are at the cusp of historical change in healthcare in India. Because at the end of the day, Viksit Bharat 2047 can happen only on the back of Swasth Bharat 2047. Thank you and welcome.
Thank you so much, sir, for those inspiring welcome and setting the tone for the day so powerfully for that to become the landmark summit. Well, building on that vision, we now move to a keynote address from someone at the very center of India's digital health transformation. It is an honor to welcome Dr. S.K. Banwal, IAS Chief Executive Officer, National Health Authority, Government of India. Ladies and gentlemen, let's make a huge round of applause and give them a warm applause. Welcome, sir. Ladies and gentlemen, a huge round of applause as Ms. Oslam Fidanchi, Chief of International Region and Member of Executive Committee, Royal Philips, welcome Dr. S.K. Banwal. Very warm welcome, sir. Over to you.
Good morning, everyone. It's indeed a pleasure to be present here among the august gathering in the program, which is hosted by Philips India and ETHealthWorld. I'm indeed privileged to see myself among the knowledgeable people who have been working in the field of AI for quite some time and have huge interest in building AI for the country, for the humanity. I see people from different sectors, people from corporates, people from government, regulatory agencies. I think it's a good occasion to talk about AI for the healthcare, for the future of healthcare in India. And being a CEO of National Health Authority, which is entrusted with the role of creating national digital health ecosystem in the country, I feel really privileged and really grateful that the way technology is enabling us, providing us the opportunity to connect different healthcare systems, creating foundations for building AI for better health outcomes. And I believe this is the time we must raise ourselves, not just to the opportunities, also some of the challenges which it actually creates while using AI, more particularly in the healthcare. I was very happy to see the address of Mr. Bharat Sesha, who understands AI so well and has been very categorical in saying that AI has to be built for the humanity, for the nation. And this is what even National Health Authority is working for. So I I'm really happy to share with you some of the thoughts which we have as regards to building AI for the healthcare in India. As all of you may be aware, Government of India 5 years back started a new initiative called Ayushman Bharat Digital Mission. And that time AI was not thought out. It was not so much, and probably we actually started this initiative to connect the fragmented healthcare system to a connected and integrated healthcare system. And it was all possible because we were building a open, interoperable, federated architecture, which we understood from our past experience of creating such digital public infrastructure. 10 years back, when Aadhaar was created, so many applications over Aadhaar was created which were primarily open, based on the open architecture. And that is what the thought behind, and we created this Ayushman Bharat Digital Mission, which is again an open, interoperable architecture. And soon we realized this has become the foundation for actually building many more emerging technology, and AI becomes the most important one. So when we created this architecture, we thought of generating digital health records, connecting health systems, and keeping patient in the center, making health records interoperable. And this now we are realizing has become a real building block for using AI at scale. Now, as we all know, that in India, people by and large have been very optimistic about use of technology, and rightly so, because we have experienced Aadhaar, we have experienced UPI, and we have seen how people adopted new technology. It actually shows the way that people, wherever they find value, which improves their lives, which improves their convenience, they are willing to use it. Now it is up to us, how do we create that framework in which they use it responsibly, they use it with trust. And this is where our role actually becomes very important. And we are finding that we need to create that enabling framework in which the use of AI becomes more at scale. Though we have seen people have started using for their day-to-day life, and more so to get many informations in a much more concise and usable manner. I think in healthcare, it goes beyond that. And that is where we have to be very clear that when we are using AI in healthcare, we should be very clear about the guardrails which we need to build for using AI. See, the whole purpose of AI is to make life of people better, make life of professionals, doctors, nurses, much more effective and much more efficient. And at the same time, we also see the use of AI should make the health outcomes better. So when we talk of a country of this size, which is not just very high population, also very diverse, which uses different health systems, I think this is the right opportunity where we can actually not just connect the healthcare system or integrate the healthcare system, but also make it much more intelligent. Make it so intelligent enough that the clinicians, as was said, devote more time on actually treatment, not on other than clinical work, which many a times our healthcare professionals are involved in. And so that will improve their effectiveness, and this will happen with more use of AI in a very responsible way. Now, we all know that AI is as good as the data on which it is trained. So many people come with AI solutions and they tell you that we are going to solve this problem or that problem. So many a times they come with a solution to tell you that you have this problem which I can solve. Instead of those who are dealing with the problem asking for a solution, I think it has reversed. And this is also happening because many a times we have not realized that how much problems this AI can solve. And therefore, we need to know that AI which is coming as a solution to your problem need to be also assessed how accurate and effective it will be in our context. And therefore, any AI solution which is not trained on real Indian data sets may not be very useful for Indian context. And therefore, we need to have the Indian data sets on which these AI models need to be trained. And these data sets are a challenge because we didn't have such a good digital health system in which the data is created in such a structured way which can be used to train the AI models. And therefore, this Ayushman Bharat Digital Mission, which tried to create the digital health ecosystem, create digital health records, and link digital health records, I think this is creating the foundation for not just validating the AI solutions, also benchmarking it. And then actually our clinicians can be much more accurate in using AI solutions for their better health outcomes. So this kind of possibility is there once we have the digital health ecosystem which we are building through the Ayushman Bharat Digital Mission. Now, going with this data, it creates some kind of a validation to the AI solutions. But again, the challenge next comes is the trust. And any AI solutions, of course, if it is trained on AI data, health data, which is Indian health data, I think it will be much more reliable. But at the same time, we need to test these AI models against those data sets. And that is where our role has become very important. We, in the February this year, came out with a strategy for AI in healthcare for India, SAHI, and this has become the governance framework in which we can actually use AI in a more responsible way. And that is what the whole crux of this strategy paper is. We have suggested 5 pillars under which all AI need to be assessed. It has to be deployed in a way that all guardrails, risk-tiered architectures are followed while using AI. And this we have developed in form of a 32 recommendations which has been suggested in that document. These documents have become the first such document in Global South. And this is very important that India has taken that lead to develop a strategy. In fact, some of the countries did make guidelines, some countries did make commission, and European Union did come out with the legislation. But we consciously decided to go for the strategy. And reason for going for a strategy is we also didn't want to kill the innovation which comes with the AI. So it is innovation which is also working in the larger framework of guardrails or the risk architecture which is associated with it. And therefore, this SAHI becomes a document which allows innovation, but at the same time also make people aware that what you should be cautious of. And this is where the SAHI's architecture is being used now, not just in the government, those who are dealing with AI in the healthcare. Similarly, now, based on the SAHI, we have started working on an implementation roadmap. We did the first consultation of different entities in the government, and we found that there are different agencies within the government and even outside who need to be very much aware of the whole way AI is going to work, and they need to know their responsibility, they need to build their capacity, they need to understand in totality how AI is going to work in healthcare. And therefore, this whole exercise of consultation is also to make them aware of their new responsibility, which is coming up with the AI. And this has come out well. This is not going to be limited only at the national level between the different ministries and the government entities. It's also being taken to the states. Because we know in a country like ours, states play a very big role in healthcare delivery. Health itself is a state subject. And so the use of AI is the most in the states. The only challenge is we need to also make them aware about the associated risk with the AI, also the capacity required for responsible use of AI, and that is what we will be doing it in coming 1 month. And I think the help of all the stakeholders are very important in that. So this is one aspect where we are going very aggressively. Most likely in another 2 months' time, we'll come out with the implementation roadmap, specifying the roles and responsibilities of different entities, their capacity building needs, and how they need to go forward to do that. At the same time, we also did one more thing, and it was done during the AI Impact Summit. We launched benchmarking open data platform. And this was very important because we all knew that AI solutions need to be tested against the Indian data sets. And Indian data sets have to be real data sets which is true representative of the whole Indian context. It has to be diverse, it has to be from across the country, and it has to be certified by the agencies like ICMR or so to treat it as the golden level data sets. And that is what we did with IIT Kanpur when we did the hackathon in January for 3 disease identification, cataract, then diabetic retinopathy, and the bone age prediction. And it came out that it is right to identify which solutions are higher in the leaderboard, and therefore people can be very much aware that whether the AI solutions being proposed to be used are up to the mark in Indian context or not. And this has been done already. Now we are working on the operational mechanism of the same, and I think soon everybody will have the option to register on both platforms, register their AI solutions, and actually validate their AI solutions, benchmark it for the Indian context. That will also help the genuine AI solutions who have actually put their effort to build solutions for the Indian context will actually get filtered out. And therefore, it is very important to identify such solution using this platform, and we have done it, and we want to actually promote it more. Of course, it is not having a legislative mandate, but that gives a good signal, good message to those who are using AI. And it is very important for all the clinicians who will be actually using AI to know where these AI solutions are benchmarked. Now, one more important work which we did, and that we did in the month of June, we all know that digital data which is now getting created through the ABDM initiative, I think these data also need to, though it is highly federated, it has to live at the place where it is created. But it's very important that these data are used with consent. And that data, if it is used with consent, actually builds the better AI models. And this can happen only if these data are created in the right standard forms. So in the month of June, we launched some of the standards with the help of National Resource Center for EHR Standards. We came out with the common law and code for India. Of course, many laboratories, they are using law and code, but in the Indian context, it was to be standardized so that the data generated by one laboratories are same and in fact are read in the same way the data which is generated by the another laboratories. Similarly, many of the health facilities use SNOMED City, but for the first time we came out with the Bharat Health Terminology Service to make it in Indian context all the clinical terms in a standard forms. That also makes very clear that the data which are in a particular facility, in a particular standard, will be read in the same way when it moves or goes to another facility. And similarly, we also launched the drug registry. So these are the standards. Of course, we have all the registries under ABDM, which allows us to actually connect the healthcare systems. But these standards are very important to generate data which can be used by AI algorithms to get trained, and also it can be validated at later stage. So these are the advantages which we are actually building. And of course, it will be more tested as we use it. But the challenge remains that in a diverse country like India, we have to think of all the variations, all the possibilities. The health system, which are as small as a single doctor clinics or as big as a multi-speciality large hospitals, we need to take care of every such facility. We also need to think of a doctor working in a very remote, hilly regions, and also the doctors who are working in a very large multi-specialty hospitals. They all are delivering health services. We have to enable all of them. And this all will be possible if we actually connect the health system, provide AI solution which is accessible to everyone. So now with technology available, a person sitting in a remote area can access the same level of knowledge which otherwise not available in such regions. So this AI is going to create that level playing for all the clinicians. It is going to democratize the healthcare delivery in the country, and it will be extremely helpful for a country like ours, which is so diverse. With these, I believe we have created the foundation. We are moving forward to create more such enabling environment in which AI solutions can be deployed at a scale. Again, once I would like to tell that, as you are also having a panel discussion, that trust precedes scale. So while there is a very high speed of AI deployment, AI usage, it's very important that we create a trustworthy framework. This is what we are doing in form of a strategy and the roadmap. We all need to think with these concepts in mind, that more so in case of AI, the trust will be always more important. The day trust and scale drifts, I think the adoption will be stalled. And that is where we need to keep in mind, though we have to keep with the pace of AI, more use of AI, we also need to build the trust architecture, which we are trying to do that. Once again, I would like to mention that AI for India is not just a technology or the opportunity. It also means, as was told during the AI Impact Summit, that it means all inclusive, And that is the motto with which we are working in the country. National Health Authority is taking the lead on behalf of Ministry of Health and Family Welfare and trying to build the architecture which actually encompasses everyone's need and builds the solution which is more responsible, more trustworthy, and can be used at a scale. With these words, once again, I thank everyone who are present here, the organizers, and I also thank Philips India for launching this Future Health Index. And I'm told for last 10 years it is being done. This gives a huge indication of the direction in which the country is moving. As it says that more and more clinicians feel better with the use of AI. Patients like to use AI for better health care. I think this is the indication, and I think today's, when we are launching for this year's Future Health Index, I think we will get a lot of insight for our own consumption and start working on it in a way that makes AI more usable for larger population. With these words, once again, I thank all the organizers and wish them all success for today's event. Thank you.
Thank you so much, Dr. Barnwal, for that powerful and clarifying keynote, and for reminding us that policy and technology must move hand in hand if we are to truly transform healthcare access to a scale. Well, what a strong foundation for the day ahead. And welcome back to everyone who has joined us online. You are in here for a treat because now we move to a milestone moment for this summit, the unveiling of the Future Health Index 2026 India report. Well, this report represents months of research and insights into where India's healthcare ecosystem stands today and where AI can take it tomorrow. I would also like to take a point out that some key statistics from the report are on display on the standees around the hall, along with a QR code that are, I think, present on your tables right now. So during the breaks today, you can scan it and download your copy. Thank you so much. Now, to take us through the launch presentation, ladies and gentlemen, please join me in welcoming Ms. Ozlem Fidanchi, Chief of International Region, Royal Philips, to the stage. Ladies and gentlemen, a huge round of applause. Come on.
Thank you very much, Dr. Barnwal, for great and insightful keynote. Hello, it's a privilege to be here with you today. This year, Philips marks 135 years of improving lives through innovation. Over more than a century, we have continually evolved from pioneering X-ray imaging to connected healthcare today and AI-enabled platform solutions. While the technology has changed, our purpose has remained the same, creating meaningful innovation that improves lives of people. Healthcare is now entering another defining period of transformation. Around the world, advances in science, technology, and digital innovation are creating new opportunities to improve care. Artificial intelligence is becoming part of everyday clinical practice, helping care teams work more effectively, supporting better decisions, and expanding access to healthcare. India is one of the most important places in the world to have this conversation. Its scale, talent, digital capabilities, and ambition give it a unique opportunity to shape how AI can support healthcare in the years to come. And earlier this year, our CEO, Roy Jacobs, joined leaders from government, healthcare, and Technology here in New Delhi at the AI Summit. He shared a conviction that all of us at Philips believe deeply. Artificial intelligence will have its greatest impact in healthcare industry. He spoke about intelligent systems that support clinicians, expand access, and help healthcare become more predictive and connected. Then in May, Prime Minister Modi's official visit to Netherlands marked an important new chapter in the relationship between our two countries. India and the Netherlands elevated their relationship to a strategic partnership with a shared focus on deeper cooperation in trade, investment, technology, innovation, and joint research. Prime Minister Modi met with leading Dutch CEOs, including our CEO Roy Jacobs, who you can see directly to the right of Prime Minister Modi, to discuss the contribution of business and innovation. For Philips, this partnership has particular relevance. We know India is a global innovation engine. Through our innovation campus in Bangalore and our Healthcare Innovation Center in Pune, teams here are contributing to our global R&D, AI engineering, imaging, patient monitoring, and connected care platforms. Solutions developed in India are used around the world, showing how innovation designed for India's scale and complexity can create a global impact. These strengths can help us accelerate trusted AI, strengthen health systems, and deliver better care for more people. The Future Health Index 2026 India report continues this conversation with evidence. From the clinicians using AI in daily practice and from the patients experiencing its impact, it helps us understand where AI is already delivering value and what will allow that value to scale in a responsible way. For more than a decade, the Philips Future Health Index has tracked healthcare transformation. This year, we ask one defining question: how is AI changing healthcare today? More than 2,000 healthcare professionals and over 20,000 patients across 10 countries, including India, shared their experience. The findings show AI is already delivering measurable impact while highlighting what is needed to scale the impact in a responsible way. The first insight is clear. AI is already delivering measurable impact across India's healthcare system. 71% of clinicians say AI has increased their capacity to see more patients. Among those clinicians, the median increase is 10 additional patients every week. 82% report improved workflow efficiency, and 80% report better access to consolidated patient data. These improvements support shorter waiting times, better coordination, and greater access to care. Nearly half of healthcare professionals also say AI helped them identifying or preventing a potential medical error, or at least 3 times in the previous 3 months. AI is strengthening productivity, coordination, and the foundations of better care. The next insight is about the foundations for scale. Healthcare professionals are enthusiastic about AI and equally clear about what they need. Integrated roles, role-specific training, clear accountability, and continued human oversight. Yet, 63% say access to AI training is unavailable, limited or inconsistent, while 86% say keeping a human in the loop is essential. Training must help clinicians use AI confidently, understand its limitations, and apply sound clinical judgment. Trust grows when clinicians understand and use AI in their daily practice. Innovation and governance advance together, creating the confidence needed to scale AI safely and responsibly. Our report points towards a practical agenda for the future. We need integrated ecosystems, continued workforce confidence, and a new model of care built around the hybrid care teams. Patients are better informed, asking better questions, and becoming more active participants in their care journey. AI is becoming a trusted teammate within the care team, supporting coordination, bringing together information, and helping clinicians focus on higher value clinical work. Together, these changes can make healthcare more connected, proactive, and personalized. Realizing this opportunity will require collaboration across healthcare ecosystem. Policymakers, providers, clinicians, academia, patients, and technology partners all have an important role to play. Philips is committed to contributing as a long-term partner, connecting people, data, and technology so that every clinician can work with greater confidence, every patient can participate more actively in their care, and every health system can serve more people. India has the ambition and capability to make a global contribution to this journey. Today, we are delighted to officially launch the Philips Future Health Index 2026 India report. I hope these insights inspire stronger partnerships and practical action. AI is already helping clinicians expand capacity, improve workflows, and strengthen care. The next phase will be shaped by integration, skills, governance, and trust. Together, we can build healthcare that is more connected, more productive, more accessible, and more human. A healthcare system capable of delivering better care for more people. I would now like to invite Dr. Barnwal on stage to unveil the report together with me.
Ladies and gentlemen, a huge round of applause. Let's welcome Dr. S.K. Barnwal. Ladies and gentlemen, can we make a thunderous round of applause for the official unveiling of the report? Thank you so much, Dr. S.K. Barnwal and Ms. Ozlem Fidanshi, for the official unveiling of the report. Thank you so much once again, and congratulations to the entire team behind this incredible piece of work. What a powerful way to ground today's conversation in real evidence and data. Well, ladies and gentlemen, we now move to our first panel discussion, which is titled as Trust Before Scale, Building Responsible AI for India's Health Ecosystem. As we have just heard, the opportunity in front of us is just so immense. It's massive. But so is the responsibility that comes along. Trust, safety, and accountability aren't just the obstacles to scaling AI in healthcare. They are the very foundation of it. So to dig into this, I would now like to invite our moderator and panelist to join me on the stage. So let's give them a huge round of applause as we welcome them once to the stage. So this session will be moderated by Ms. Shipra Malhotra, Tech Editor, ETCIO, The Economic Times. Ladies and gentlemen, a huge round of applause. Welcome, ma'am. And joining her are our esteemed panel members, Dr. Mona Duggal, Director, ICMR, National Institute of Research in Digital Health. A huge round of applause for Dr. Mona Duggal. Now I would like to invite Dr. Kritika Rangarajan, Head of AI Center of Excellence, AIIMS, Delhi. Let's make a huge round of applause, ladies and gentlemen. Come on. And now I would like to invite our next panel member, Mr. Nico Shitakate, Counselor of Health, Welfare and Sport, Embassy of Netherlands. A huge round of applause. Come on. And now I would like to invite Dr. Bishnu Panigrahi, Group Head, Medical Strategy and Operations Group, Fortis Healthcare. A very warm welcome to all our panel members and our moderators. And now I would like to request Dr. Malhotra to please take over from here. Thank you so much.
Great. Thank you so much. It has been a wonderful morning with the keynote address by Dr. Bernwal, and the conclusion of his keynote is something which is very critical and leads into our conversation and into this panel discussion. We see is that the AI opportunity in healthcare is no longer just about proving value. It is about building scale. But scaling AI in healthcare is no longer just a question of technology and innovation. It is a question of trust, and very well put across by Dr. Banwal when he said that trust needs to precede scale. And that is what is going to be the crux of our conversation today. Factors such as the quality of evidence, data governance, patient privacy, interoperability, clinical validation, confidence of the doctors and the patients, they all determine how far AI can meaningfully scale. And so therefore today we bring across diverse perspectives from the healthcare provider point of view, from policymaker point of view, and from research point of view as to what it takes to create, to scale AI, as well as the foundations that go into building that scale. So let me first start with talking about what does it look like scaling AI, and or rather what some of the healthcare providers in India, what they're doing to scale that. So Dr. Kritika, let me start with you. How has AIIMS adopted AI at scale within its workflows? I remember you mentioned that it is about research first and then scaling. So what is it that you're doing currently to build that scale?
Yeah. No, thank you for that, and thank you for really putting into context, as was said in the morning, that trust has to precede scale. And as a clinician, somebody who deals with patients in the real world, there can't be anything more important than that. And that's the reason, sort of when we chatted in the morning, I would want to be very, very careful about talking when we talk about scale. Because, when you try to find shortcuts in order to scale, then it fails by default. So what would end up happening is that, for the sake of completing your records, because it is mandatory to use it, on paper it will look like AI is deployed, and in the real world you would have bypassed that and found ways to go get past it. So really I think the crux of what we are trying to do is focusing on adoption. Really talking about what is it that makes the doctor truly rely on AI, and what is it that makes them say that, no, I'm not going to touch this. Because much too often, if you look at any AI model that we do in the real world, we're talking much too often about efficacy metrics. We're talking about what is the accuracy, what is the false positive, what is the true positive, what is the true negative. But when you actually come, with a patient in front of you, if that patient is a false negative, then that's 100% for that patient. And I think it's very important to understand that. So the question we're trying to ask, we've moved beyond the model building stage. I think all that is done. It's a highly democratic world, and I don't think the challenge lies in how do you build a model. The question really has come to how do you utilize this? How is it really helping the doctor? When is it that the doctor says, I would like to have a look at AI? So should it be a push AI or a pull AI? Does it actually help in upskilling, and at what level? So do you give it, how is it different when you give it to a junior resident? How is it different when you give it to a faculty radiologist or a faculty physician? How is it different when you give it to a technical staff? Does it actually help you upskill the technical staff and increase capacity? I think these are some of the questions we're asking right now.
So these are all the areas where you're currently working on in the Center of Excellence at AIIMS. Okay, so while we see that patient privacy and when we talk of data governance, etc., all these are important pillars of trust, but like you said, confidence among the doctors and the patients is going to be, let's say, at the core, at the crux of building this trust. So, Mr. Shikate, I hope I pronounced it correctly, or if you can let me know.
You can call me Nico as well.
Nico, okay, yeah. So I think that will do. So Nico, how has the Netherlands integrated AI into its healthcare system, and where do you see the greatest real-world impact coming in?
Thank you very much for this question. Very happy to be in this panel as well. Feels like a family reunion because we know each other. First of all, let me congratulate Philips on the launch on this Future of Healthcare Index. Last year, we organized this launch at the residence of our ambassador. And talking about scaling, it's really great to see how this event is being scaled up every year by Philips. So all my respect and compliments to Philips and their entire team. Now, I noted down some pointers from the previous speakers that I will try to integrate in my reply to your question. So first of all, let me say that in general, from an EU perspective, and there's also from a Netherlands perspective, diligence and carefulness precedes speed. And that's exactly what I heard the CEO of the NHA, Dr. Barnwell, say as well in his keynote speech. So how does this translate into the reality of the Netherlands? That was your question. Is that we decided to establish the supervisory landscape and the AI realization program before large-scale scaling up. And then getting more in, so first proven value and trust, and then scaling. Now, how does that translate more concretely? My Minister of Health sent to our Parliament already some time ago our AI realization program in healthcare. That has 2 tracks and 5 programs. Track number 1 is about readiness. And readiness is about governance, is about ethics, etc. Track 2 is about implementation. And now there are, along these lines of first proven and then scaling, also applies to the breakthrough resources, financial resources, that my Ministry of Health has just determined for 5 specific, what we call model plans for national scaling that have just been determined almost as we speak. First of all, on digital triage. Secondly, on capacity planning. Thirdly, on speech-driven reporting. Fourthly, on telemonitoring. And finally, also on home monitoring. Your question, your sub-question on impact, 2 aspects. First of all, reducing the administrative burden on healthcare professionals by 50% in 2030. Very clearly targeted. And secondly, it was already mentioned, and I think in the next panel discussion we'll talk about the burden, right? on healthcare professionals. Secondly, is about the impact is in imaging, especially in relation to analysis, but also diagnostics. Think about radiology or pathology. And all of this is being embedded in our national agreement on healthcare and well-being, in which participate healthcare entrepreneurs, healthcare providers, all our municipalities in the Netherlands, ministries, federal medical specialists, GPs, nurses federations, etc. And obviously all of that enabled by our healthcare information system at national level, a little bit like ABDM here in India.
So what I see is that whether it is a healthcare provider at an individual level or it is a country's healthcare ecosystem, I think the fundamentals remain the same. It is trust, proceeding, scale. And when it comes to the real world impact, Dr. Panigrahi, I want to hear from you, how far as a private healthcare provider, how far are you from an integrated AI ecosystem, integrated AI systems where we can talk of impact such as reducing the waiting times, improving the clinical outcomes, improving patient experience.
First, I'd like to thank Philips for organizing this. This is a great session and have great co-panelists also with us here today. Fortis Healthcare is looking at AI in a different ways that as the session started off, it has to be trust before scale. So unless we have that, because as they say, to get anything implemented, you have to have the buy-in of people. So buy-in only will come in if you know that it is safe, it is scalable, and the clinicians benefit from it. And most important, we are able to deliver good outcomes as well as patient experience. And as you rightly mentioned about the patient experience part, I think so when a patient walks into the hospital, sometimes they get lost. So this is where AI comes into play also. If you have this standees with the chat box, they can be directed. You don't have to think, they don't have to keep on asking where we have to go. So this is another thing that we have started implementing it, and we are finding a huge advantage in that. So because we capture our patient experience by the Net Promoter Score, and we are seeing a northward movement there. So I think so these are small things that are coming in. And on clinical outcomes, I'd like to share here is that Fortis Healthcare has been a prime mover in publishing outcomes since 2016. And digitization has happened. Again, it's just a coincidence that I'm sitting in a Philips forum. And it was, we took the help of a company called Vital Health, which was a Philips subsidiary. They don't exist now. But they helped us develop a data set for looking at clinical outcomes for CABG, PTCA, TKR. So since then we are having this, and every hospital where we are having decent volumes, we are capturing it and we are publishing it. And the last 3 years, in fact, the reports also have been come out. So why I'm saying this is that because when your data never lies, and all clinicians are smart, so when they look at the data, they know where they can improve upon. I'm just giving a simple example. Being a cardiac anesthetist, for a bypass surgery, the gold standard is a Lima to the LAD graft. That's the gold standard across the world. And if you look at good hospitals, they should be having around 75–80% of Lima to LAD. So why I'm saying this has been captured everywhere. One of our hospitals, they were in that mid-50s. Which is something no good hospital should do it, whether it's the public sector or private sector. So over a couple of months, and I was just waiting for, are they going to look at it or we have to intervene from the top? Because I think intervening from the top is not the right thing. They should realize that something is not right. And believe it, after a quarter, after 3–4 months, I started noticing the numbers going up, and they are in their mid-80s now. So I'm saying data never lies. So this is where if you start digitizing the data, keep it there, share it with your doctors, there is where the improvement will happen.
Yeah, absolutely. Your emphasis on data is very important because all the patient outcomes, identifying new treatment pathways, all this is based on data and of course trustworthy data, and we will be talking more about that as we go forward in this conversation. Dr. Dugal, you've seen from what we have heard in terms of some of the use cases that we're talking about, and overall if we look at the overall ecosystem, India has a vibrant AI innovation ecosystem in place. So how do we ensure that the innovation that is coming out is matched by robust scientific evidence before the solutions are adopted widely?
Thank you. I think excellent comments. I will actually start with Nico. I think, Nico, the first track that he said is the readiness. So I think the readiness is where it starts. Like, you have to have a ready workforce that should be able to do it. So I think we are working on a multi-pronged strategy as of now. I think when I started my career, I think it wasn't like, it was long back. I was in US, came back. 2017 was a right time. I remember that the first start was at the NITI Aayog when we started with the validation study for the diabetic retinopathy. That was the first study that we started. And since then, it has been a 9-year journey. And that time, there was no awareness. I think as of now, with the India AI Impact Summit, that awareness has been created. So once that awareness, we have that 5 scale, right? Earlier, it was, nobody even understood you have to have data, right? Second was, what is ethics? So ethics was a very Western concept. Mind me, I still remember like when we used to do like, if you know how the Indian clinics work, you say consent. Do you really understand consent? What is it? It was like you were doing research studies. What is consent? It was a very Western concept. So all those things were very, very in the nascent stage. But with the impact which the AI has come, I think we cannot look away anymore. It is like, it is now or never. So the first thing, I think if you are aware, we had an AI ethics guidelines that came out in 2023 around that. That was released by my previous namesake, that was the National Institute of Medical Statistics, now the National Institute of Research in Digital Health. Now we are again in the process of upgrading it further. So it has become like a living document. So you cannot have like policies and guidelines that are coming that can stay. It has to be updated continuously based on the real world evidence that is coming in. So now again, we are now updating it because when we released it, we did not have something like agentic AI or something. So now we have the use cases that need to be upgraded further. Second, I think there was recent upgrade of ethical guidelines overall. For any scientific evidence, we need multi-centric trials. Earlier, every time it used to be like, you had to have like multiple ethical guidelines. Recently, again, as ICMR has upgraded it to simplify the process. So the one lead PI will take the ethical ethics clearance, and it's easier for the other sites to do it. So as the scale is being talked about, the matching governance guardrails are also being talked about, and that is being done parallelly at the Department of Health Research and Indian Council of Medical Research. That has to match that speed. Then also second is the data sets. I think the best data sets as we talk has to be, again, that will be coming out of the research data. So this is something that we already have around, we fund around 500 plus medical colleges and AIMS and others, where you have trained research personnel. They get funding for research studies that are the cutting edge. And then we will be able to identify which are the areas where we can actually generate gold standard data sets, which Dr. Banwal had talked about. So this is something that is being talked about. But coming to the point, it is not only the gold standard data sets. The other data that is being created through the health systems, there are data that is being collected even in the private sector, and they are willing to share that data. How do we get that data into the mainstream? Identify those data sets, because this is the need of the hour. So as we are talking, the data sets will be created in parallel. That is, of course, the prospective data. We know how we collect the data. We are having the multicentric. The secondary data that has been generated, which is actually lying with many of the hospitals, they are willing to share. The third is, how do you streamline the research component, where we can actually strengthen the data collection part? I still remember our times, I think Prinsika will be there. Data collection was probably the last part we have actually thought about, and suddenly now it is the top. A simple data collective is like paid like 30,000 in our budget, so it is the lowest. But now suddenly I think we can't even think about it. They are the top. We will have to actually have that parallel, pay them equally, and now we have a non-medical staff that is being paid equal to a medical staff because we understand the importance of data. So that, I think the parallel systems in the research are being developed. And the last thing I think in ICMR, we have something called the Model Research Health Units. And they are like both urban and the rural. And we have around 97 medical colleges where ICMR is working very closely and having the research units. So that network can be activated now. The governance mechanism needs to be updated. We need to strengthen the validation units. And then we have the HTA committee has been formed for AI specifically. So we have 20 HTA resource centers, but now we have been tasked to develop the HTA resource center that needs to be done. So as we are talking about scale, I think the research and the scientific evidence part is being developed parallel. As we said, we have to be very fast. Of course, research and evidence takes time, but then as we are talking, I think we are trying to match as fast as we can.
Right. So I see a lot of emphasis being placed on data, and rightly so, because the quality of data that you input into the AI systems is going to determine the output as well. And like Dr. Kritika mentioned, the models are not the problem here, or rather they are not the challenge. We have enough models, and continuous innovation is happening, but what do you feed into the model is critical. And also data is the foundation of trust. But before we move into the foundation for building a trustworthy AI, let's look at what exactly does trustworthy AI in healthcare really look like. So Dr. Kritika, what does it look like to you? And also, how should healthcare organizations validate AI before deploying it at scale, particularly in a country like India?
No, I think thanks for asking this question, because I think now this era that we're in is the first time that you can't just copy paste, right? Like 20 years back, if there is an MR equipment or a new sequence that came on an MRI, which was invented in the West, it would be the same sequence that comes to India, and you would, with fair expectation, expect it to work in a very similar manner. You didn't need to validate that sequence. Yeah, I mean, you did for specific clinical purposes, but you wouldn't expect a massive difference in the way an Indian patient behaves versus how a Western patient behaves as far as certain equipment is concerned. And suddenly here comes AI, and here is a technology which is going to be dramatically different. So it's not, you can't just copy paste a solution which was invented in some other part of the world. So I think that, I mean, and let's not get to some other part of the world. Something which was, built out of AIIMS may not work in Fortis, which might be across the road to us, because the patient populations are so different. So I think, here we've truly come to a stage and age where technology has to get married with healthcare knowledge, because if you didn't know the variation in your patients, you wouldn't know if this model or this AI solution is really going to work in your sort of solution. Having said that, what I would say is one of the things that we do sort of advise caution on is that we need to sort of see our own experience before we start relying on what papers say. What papers say necessarily is usually, lab data is very different from real world data. Accuracy metrics that we see written out simply don't translate on ground. We've had experiences where, for instance, in diabetic retinopathy, which you worked on, so extensively, things work perfectly in the lab. You have excellent results in the lab, and suddenly when you go to the actual community, the lighting conditions are so different. The staff who's acquiring that data it has such a different level of training. The equipment you're using is not the standard, the on-table sort of perfect images that you get from them. The resolution is so different that the performance varies completely. I work in mammography, and when we started our work, we saw that models which are published in literature had completely not seen the kind of large cancers we see in our data. We see very dense breasts in India. We see mammographically dense breasts in India. And models which were benchmarked for best performance at that point in time, this was 10 years back when I started working on this, completely failed in India. And they completely ended up missing the large cancers. What can we do about this? I think the first thing that we are trying to do is we're trying to put out open data sets, like Dr. Mona had also mentioned. We're trying to define what Indian clinical variety looks like, trying to make them publicly available so that these models can be validated in Indian settings. We also do try to put out guidelines like, do try to validate it within your community before actually relying on it completely. Again, in terms of education, we're also an educational institution. We train, the doctors of tomorrow, and very important to make them understand the importance of where AI can fail. It's very important for students in training today to understand that AI is not foolproof, and therefore the complacency bias does not, should not creep in. You need to sort of rely on your own clinical judgment before you can actually rely on what AI is saying. And you need to be the person validating the model, which means, again, when we train our residents, we try not to assist them with too much AI at the moment, because that would hamper the development of their clinical skills, which is what is going to be the safeguard in future, against AI performing not as well as it is supposed to. And we're trying to define, metrics like how often do you need to validate AI, how much difference in performance should be considered, a red flag so that you start revalidating, how much of a data drift or a model drift are you allowed to sort of experience. So I think these are nebulous questions. We don't have answers to these honestly, but we're trying to, that's the direction we're trying to go to. Right.
Because when we talk of validating AI before scaling it, you mentioned that very rightly so, that in the lab environment, it's very different from the real world. It's a perfect controlled environment in the lab, whereas, it needs to be validated and be ready for external environments in real world environments where, like you said, the lighting may not be perfect, the data sets might be completely different and not what you tested on in the lab. So Nico, what does trusted AI look to you, and what does it take to build it? Especially how critical are aspects like interoperability, common standards, and international partnerships in creating these trustworthy AI ecosystems?
Thank you very much. An excellent question, by the way. I think you said the magical word, validation. Validation is really crucial. And the importance of interoperability standards, and also for creating international partnerships, I think interoperability is crucial. Without interoperability, there will be no trustworthy validation or generalization of AI models. And now, of course, I am from Europe, and in Europe we have different healthcare systems, we have different languages. I had to think a little bit when Dr. Barnwal was saying on the diversity in India. We have also similar types of diversity within Europe, right? We also have different languages, we have different ways of financing our healthcare systems, we have different levels of digital maturity. And at the same time, the very good thing is that we have the European Health Data Space, better known obviously under its acronym EHDS, which is exactly addressing this aspect of diversity by ensuring availability of data, but also safe exchange of data, and at the same time also the secondary use of data. And this is exactly, for instance, with Dr. Mona and her team, what we are looking at, how we can work together between Europe and especially the Netherlands and India on specifically this point on secondary use of data. In Europe, we have also, Dr. Barnwal was also referring to this, the AI Act. Worldwide, this is the first legal framework for AI systems. In parallel to that, we have the AI Apply strategy with 1 billion euros, that's a lot of money, investing in the application of AI. So I think that these 3 elements together, the EHDS, the AI Act, but also the AI Apply strategy, we are well set to create these partnerships with our partners in India, rightly, as Dr. Barnwal said, with SAHI and both being published and now working on the implementation. We've made an analysis at the embassy of a lot of overlaps that exist between this EU and the Netherlands context and this context of SAHI and both. And we see a lot of opportunities. SAHI and both have a wonderful, I would say, converging force and converging drive in addressing these diversities, and we have exactly the same in Europe, and now the trick is to find the bridge between both of us.
Right. So Nico spoke about the importance of international partnerships, Dr. Mona and Dr. Panigrahi. I would like to understand from you the biggest opportunity, or rather the importance of public-private partnership and the biggest opportunity that you see in these kind of partnerships. So Dr. Dugal and then Dr. Panigrahi. Yeah.
I think research, traditionally it has been international, and of course you have the national and then you have the international, I think, and the public-private partnership. Let's be very clear, most of the technology and the development is happening at a very rapid pace in the private sector. But when it comes to the guardrails, policy, and the implementation and the scale, it has to be by the government. So unless and until those two match, that is not going to be there. The good thing is that when we started at the point, it was very government. Now it has opened up. So I think it's not like if you talk, go into a government office and say we are from the private, the doors are going to be shut. Or you are going to be looked at, okay, there are trust factors. So I think we have overcome the first part. And that now there's a trust factor, and I think at the government level also we understand at the pace that the private sector is going, we will never be able to do it. So even when I was designing my vision statement for my institute, I think I was very clearly told, Mona, you cannot do it, you will have to enable it. So our vision statement was to enable the ecosystem so that there's a very strong public-private partnership. Even within ICMR, if you see, we have now the Patent Mitra and we have the MedTech Mitra. So these are the two things that have now come up, understanding that the ecosystem needs to be now very private friendly. So that is there. I think one thing that always comes to the thing, and which probably we are all struggling, is when you have AI tools that come into the market, how do we validate it and how do we get them integrated? So this is something that I think we are all still struggling with, and that policies and the governance frameworks are being done. Because most of the tools that are being developed, as you rightly said, are developed on the Western data set. So now it is the government that needs to make sure that when somebody comes in, if they have been validated and trusted, they can get the initial license. But as and how, what is the journey and how do they get integrated into the Indian system, that needs to be there. This is as per the medtech thing I'm talking about. Second is the research component. Now, even in research, I understand when the European Act came in, the research, the international, the data sharing work became nil. I was reading about it. Many of the research studies, traditionally we have shared data that is anonymized. It is as per the standards that have been there. But when I think the European Act came, the sharing of data had become a problem. So, but now I think these are similar questions that are being asked within the same ecosystem. So we are now looking at frameworks like DEPA, that is the Data Empowerment Protection frameworks, where we have, where the model goes to the federated data sets. How do you take the data out of, not taking the data at where it is there, but the models can be tested in those settings. Second is anonymization. How do you anonymize the data? What are the mathematical models that need to be applied? Earlier, the problem was we did not have the understanding. Now the thing is, as you are getting more understanding, the research is also going to be, the skill sets needs to be done. But again, in the international setting, as we said, the medtech and the industry part, that is being taken care of. I think the CDSCO, we are working with the CDSCO to have how do you actually test it, how do you get them registered, the initial registered, and as they get more better at within the Indian system, they get registered. So that is the first part. Second is the research part. How do you share data? What are the best practices that need to be developed so that the researchers are aware that when you are sharing data and when you are partnerships are being developed, what is the framework that needs to be developed? That is the second part that is being developed. Third is the public-private partnership. As I said, there is an understanding, there is a very rapid ecosystem, and again, the states are now opening up the doors. So those frameworks are already being developed. So I think that understanding that there has to be a public-private partnership in this research ecosystem and others for the scale-up is very much there.
Right. So Dr. Panigrahi, Dr. Dugal spoke from a research perspective. From your perspective as a private healthcare provider, what are some of the biggest opportunities that you see in public-private partnership in building trusted AI in the Indian healthcare ecosystem?
See, public-private partnership, I'd like to say first is that the barriers need to be broken down. There's too much of a barrier, we work in silos. So finally, who's the person who's going to benefit? It is the patient. He's an Indian citizen. So I think so, and I'll speaking from a personal example, for 2 years I was in Orissa helping a healthcare company to upgrade during the COVID time. And the public-private partnership across the sector, across the state, helped in putting up COVID hospitals. It was for the government, run by the private sector, and different private sector places. So I was one of the providers there from the Kalinga Institute of Medical Sciences. And we put up 1,050 beds in the capital city as well as in tribal district headquarters. And what the thinking was that private sector can scale up much earlier than the public sector. So what I'm saying, that's why I said the barriers have to be broken. So if you do that, that will help a big way. And the data, as was mentioned, I think so we have to have a proper data infrastructure because AI will not drop down from the heaven. It will come with whatever data we capture. So the data has to be the EMR platforms across, whether it is irrespective of the public or private sector, has to be standardized. I think the government of India is working on it, but we need to standardize that these are the mandatory data sets that have to be filled in for every patient, irrespective of where you engage, public or private. Then what happens, these data will be the source. This is costly currency, if I can call it, the data. Because then you can look at it, because India is a huge, it's like a continent, and every area has a different demographic, if you look at north, south, east, west. So our data will have a lot of bearing there. So when you have that, this humongous amount of data, it will help in the health economics. Your disease prevalence will be known respective to the geographies. You can plan your resources accordingly. So healthcare planners also can do it better. So I think this is something very important. The data sets have to be, first of all, properly standardized, irrespective of public-private. That needs to be mandated and put. And I think so the governance councils, the governance frameworks are being put in place, the size, the strategy that is being put in place, the others that build on the open data platforms. So a lot of good things are happening. I think so we need to scale up much earlier. We should do what we should be doing tomorrow, today, not what we should have been doing yesterday, today. So that if we do that, I think so we'll be getting in the right space and moving ahead.
Right. I think from the public sector side, you've got very rich data sets that are available and at a scale, because we are talking of a huge population. And from the private sector side, the ability to scale faster.
Yeah, so just coming on that again, see, like was mentioned, Dr. Raghuvanshi, who is a cardiac surgeon, who is the CEO of Fortis Healthcare. He's part of the Nat Health initiative for working with the government and NHA on the data sets and all that to standardize it. So from our side, we have already our EMR part. Whatever needs to be put in the ABDM has been put in place. So whenever that is rolled out, we'll be there. So what I'm trying to put across is that we can't be an island. It has to be across the public and private sector health ecosystem, that these data sets have to be now systematically plugged in, because there's a value to that. And the patients and the clinicians' workflow should also be there, so they feel that this is beneficial to them. It's not that technology is being imposed. How do they benefit in their workflow by using AI?
Absolutely.
How will the patient see that it is not the AI which is directing them about the treatment, it is the doctor but who's doing it. It's just an enabler.
Right.
So these small things will help.
So we spoke about what trusted AI looks like, and also the role of partnerships, international partnerships, public-private partnerships, the role of validation. Now let's look at the foundation of building that trustworthy AI, or rather trusted AI, which is the data governance, interoperability, privacy. So let's talk about that. And Dr. Rangarajan, given AIMS, medical expertise and rich patient outcomes data, how does the institution put appropriate guardrails around patient privacy and responsible AI adoption?
So I'll take this in 2 steps. You mentioned clinical expertise and data. AIMS is certainly a very rich sort of bed of data, but I would like to focus on the medical expertise before I come to the data, because much too often, I think, and especially because it's a large medtech company, Philips, which is organizing this, and something that I always tell medtech is, when you go to the doctor, don't ask them for their data. Ask them what your problems are. How can I be useful to you? How can I build out something that actually eases out your workflow, and the data will flow in much more easily. So I think that's the first point that I'd want to make. I think we should make use of the deep medical expertise we have within this country, deep understanding of what our medical problems are, because if we go from problem to solution, we're much more likely to get adoption, rather than much more often what happens is we begin with data sets because they're available, we build out the technology, and then it's a technology looking for a problem to solve, rather than a problem looking for a technology to solve it. So, so really, I think the first thing is the deep medical expertise aspect of it. The second, about the data, I would very much want to come back to Sir's point on, we are all familiar with the kind of public hospitals we have in the country and the kind of workloads we have. So if you go to a public hospital like AIMS, if you've ever visited the OPD of AIMS, you have 200 patients actually listed for each day per doctor. You have to see them in a matter of 3 hours. So if you add to their work list and say that in order to get compliance, you need to do 5 extra things per patient, this will not happen. I mean, let me assure you, it does not happen. The reason why our data is not as available as we would like it to be is because medical data is essentially unstructured. At the moment, we have to find ways of meaningfully structuring this data, but without actually impeding the workflow of the person who's doing this. I think this is what we're working towards. How do you leverage technology to make this easier for the doctor? So can you actually have an ambient scribe? So I think much too often when we think of AI in healthcare, we think of this magical AI doctor who's going to solve all the problems and replace, and I don't see that happening. I see AI as giving a whole lot of a different picture, maybe a more boring picture. It's possibly going to be there, but allow the doctor to have more face time with the patient. Allow the doctor to become the healer that you're supposed to be, rather than looking into the computer and typing 20 things. So I think what we're attempting to do is exactly that. How do we capture some of this very precious data which we are not able to capture today, but do that with the help of technology, and then that becomes the bed for further things. Guardrails for patient privacy, I think we follow everything which is sort of standardized across the world. We don't have patient identifying information linked to this data, so that it is de-linked completely from the identity of the patient. We also try to use aggregated data as far as possible, so that it doesn't come down to the question of one patient whose data we may not like to reveal.
So responsible use of data, I think, is one of the most critical foundations. So Nico, Europe has a diverse healthcare system. So what challenges does this create for seamless data flows and the responsible use of AI, and any learnings that you would like to share here?
I think what is important. I think this question of standards is a very important one, and I think that the good news is that there are already some standards that do exist, like the NEN 7510 standards, the HL7 fire standards. So those are not nice to haves; those are preconditions. And that exactly allows us and also prevents all of us, be it a government or a country, knowledge institutes, hospitals, companies, to reinvent the wheel. And I think this is also what allows us to do these international partnerships that you earlier referred to. So I think that that's where we have a lot of common grounds where we can all play our roles and contribute to.
So Dr. Panigrahi, what will it take to drive responsible AI adoption in India? So as a healthcare provider, what do you see in terms of data, in terms of privacy, in terms of interoperability? What are those foundations that need to be built?
See, I think so. The way NHA is trying to configure everything, the ABDM, the PSI coming in, the BOLT coming in, the crux has to be at the primary health center and the district health centers. I think so. Where we are sitting, it is in India. That's, I call the metros India. If you have to make a success of it, it has to be in Bharat, in the primary and secondary health centers and the district headquarters. Because if you just look at our some of the things that have been phenomenally done well is a lowering of a maternity mortality or infant mortality. It has been done at the grassroots levels, and they have used technology. It's not that the ASHA workers, they have the tablets, they go around. So what I'm saying is that while we get a structure in place, which NHA is doing, that needs to be sort of dovetail and parachuted at the primary health center, secondary health center, and district headquarters. Because if you look at it, UPI wouldn't have been successful if Bharat would not have been using it. Metros, if only it was been using metros, UPI would have been a failure. Across the country, if you look at it. So I think this is where our focus should be. So while we standardize the data sets, see that the guardrails, as was being mentioned, have been put in place, it has to be parachuted there, and we have to move ahead. I said, it's not a perfect world. There will be mistakes which will happen. We'll course correct. But if you wait for a perfect solution, as I say, perfection is the art of the evil.
So, Dr. Dugal, you spoke extensively about how AI research increasingly depends on data sets, health data sets. Now, how do you suggest, how can India enable innovation while protecting privacy and looking at data governance and privacy aspects?
I think we are already looking at it. That's what is it. We are already have the data sets, like ICMR already has a national repository. Earlier it was like, and again, if you look at it, we have the IBDC at the DBT and the DST level. So in India, if you look at the research ecosystem, we have three main bodies of where the research money comes from. Indian Council of Medical Research, that is the Department of Health Research that falls under Ministry of Health and Family Welfare. So this is something that is extensively works with the medical colleges, the national institutes of importance like AIIMS. So this is where the medical data comes in. Then we have the IBDC or the bio on the genetics. That is where the DBT and the DST, that is like the Anusandhan Research Foundation, where a lot of that research and the breakthrough research is happening at that level. So we see all the two, so both DBT and DST come under the Department of Science and Technology. Overall, the ministry is the Science and Technology. So we have these two ministries, and now both the ministries under which these three funding bodies come have now the repositories that have been developed. So ICMR has its own repository of the data. That any research that is being done with ICMR funds will need to be deposited in the ICMR data repository. Secondly, at the IBDC level or any research that is done with ANRF money, the research data that is being generated is going to be deposited there. So now there is a movement. Earlier there was no understanding. It was okay. It was sitting with most of the researchers. So researcher will do the study. It is with individual researchers. There will be no collaboration. So now there is a movement where there is an active intervention from the research bodies. You are going to be using the public money. So we will request you to put whatever the research that is being done, a copy of that research into the data repositories that are being there. So this is the first step. Now, how do we actually do the matchmaking? So for the similar research problems, you have an elephant, I think, and every aspect is being dealt by a different researcher. So somehow we can actually get those researchers together and identify if we are having the same problem, but different aspects are being done. How do we build an intelligent layer on top of it? So this is something, again, that is being not talked about. We are now discussing it with the different stakeholders and identifying so that we can use the public money in such a way that all the innovation happens, but at impact level. Because you do not want to have fragmented. You have, for the same researcher, if he is going to 3 different agencies, of course, a part of it is going to be funded. But then you will also have different researchers probably working on the same problem. If we can actually identify people, build knowledge graphs on top of it. So I think the research is going to be at impact to scale. So this is how probably now we are working towards the knowledge graphs, identify researchers working on similar problems, and concerted efforts to use the public money in such a way. And in fact, I think the MIT is now building a UPMS, that is a united system. Probably at some point, or everybody from all the 3 research organizations will need to actually identify the call for proposals. The research calls and who is going to be applying for the research is going to have a single window. So it's not only for only our research organizations, even others like the agriculture and anybody who is doing research in the ecosystem will probably go through that system. So we know exactly what research money is going for which research funding and who is working on what. So there's now a concerted effort to identify and close the gap and where the research money is being given.
So from a research perspective, also from a technology perspective, I think the 2 foundations for trusted and responsible AI will be data privacy. Of course, we spoke at length about it, and especially with the DPDP Act now, the responsibility and the onus on the data fiduciary is immense. Secondly, from a data security point of view also, because we are seeing a majority or rather a huge percentage of the cyber attacks in India happening on healthcare institutes, and we have seen, we have an example here also. But the point is that especially now we are seeing the agentic systems, especially with agentic AI coming in, we're talking of autonomous systems. So I think that is where data governance and data security and privacy will become very critical. Now let me move to the core of what we, of this conversation of trust before scale. I mean, another core aspect is governance and standards and institutional confidence. So, Dr. Dugal, I want to continue the conversation with you. Now, should India develop a national framework for evaluating healthcare AI analogous to the structured evaluation of medicines and medical devices, and what might such a framework look like?
I think we are already in process. So there is a the evaluation framework, like because there's a risk-tiered framework that we are already talking with CDSCO, because I think that is important to understand how this can actually fast track. So many of the evaluations, we need to make sure that how much evaluation is required for which AI tool. It's not that every AI tool will require the same level of evaluation. So that risk-tiered framework is needed, and that is something that we are already in talks with CDSCO, and that is also part of the SAHI framework that we are now talking to. So one of the pillars, if you look at, is already there, and we are working very closely on that.
Right. So we have about 8 minutes left, so I will quickly, conclude the conversation with questions. One more question for everyone here. So Dr. Kritika, again, on the frameworks and standards part, how can institutions such as AIIMS help establish standards for evaluating AI solutions and build clinician confidence in their use for patient care?
So we're working very closely with ICMR, for instance, and I think what Dr. Dugal mentioned about the risk assessment is a very important part of it, because you don't need extensive clearance for something which is helping in record maintenance, for instance. You don't need extensive evaluation for something which is deterministic and not probabilistic. I mean, so things like that, we need to identify what level of direct patient risk is what AI offers at these different levels. And that's something that we're working with these organizations on. I would just quickly touch upon one more aspect of it before you could move on, which is the efficiency-based metrics. I think right now we much too often focus on efficacy metrics, where we're looking at what is the accuracy of AI. But even if something is 90% accurate, it still means that I, as a doctor, need to spend all that time in first verifying what AI has said, and then give my own opinion, which might end up meaning that I take double the amount of time in actually doing that. So I think we need to move towards efficiency metrics, not just efficacy metrics, and that's something that we're working on. And the third aspect of what we're trying to work on right now is also about where does this really fit into the healthcare system? Because we come up with all sorts of new AI-driven interventions which can help different disease entities. But does this actually, what is the cost to the system and what is the benefit to the system if you actually introduce that, is something that only a health technology assessment and a health economic analysis can actually bring.
So concluding questions for Dr. Panigrahi and Nico. Dr. Panigrahi, what would you recommend to government and fellow healthcare providers for accelerating responsible AI adoption?
Again, the data interoperability depends on having a standardized data set across the healthcare ecosystem. So this is the most basic thing. So, and for that, the EMR, electronic medical health records, has to come in place. So irrespective of public-private partnership, this mandatory data set has to be entered. And my focus, as I said earlier, has to, again, while we develop it here, quickly see that at the primary health center, secondary health center, district headquarters, these are implemented. And review that, and there will be course corrections depending on how things are. And see that this is an enabler, not a driver, because it is the clinicians who and nurses who actually show empathy, not the machine.
So Nico, quickly, I'm getting feelers that we need to wrap up the conversation. So to conclude the conversation, what role should governments, healthcare providers and other ecosystem stakeholders, what role should they play in accelerating responsible AI adoption?
You want me to reply very quickly to that question?
You can definitely take 1 minute.
No, I think maybe I will quickly summarize that in our experience in the Netherlands and focusing on this issue of trust, right, Bharat, is that trustworthy scaling starts with shared, pre-tested model plans instead of isolated pilots. That as such, that principle is applicable anywhere, irrespective of the context. And if there is maybe kind of a last word, if you allow me, is that I think we all, whether we're a healthcare provider, in research, in hospitals, in the corporate sector, in government, like me, what we all need to do, I think, is prevent trust from being damaged by scaling up too quickly.
Absolutely. I think that's a great way to end the conversation, and a very engaging conversation. So, we are up on time, so I will not take too much of time, but I want to refer to the opening remarks, which was about, it's not just about human in the loop, it's about human in the lead, and I think that says everything about how critical trust is in responsible AI adoption and scaling AI adoption. Thank you so much. A big round of applause for all our panelists.
Wow, what a rich, candid conversation. Thank you so much, Ms. Malhotra and our entire panel team for sharing such valuable insights with all of us. I would request the entire panel to come forward, for a group photograph. And now I would like to invite Mr. Bharat Shesha, Managing Director, Philips Indian Subcontinent, to please join us here on stage to felicitate our panel members with the planters. Ladies and gentlemen, can we join our hands together once again for the panel for such a rich conversation that we have witnessed. Thank you so much. Thank you so much. And Sir Bharat, sir, I would request you to please join the panel once again for a group photograph. Ma'am, please join us here. Thank you. I request the panel again to have a group photograph with Bharat, sir. I would like to thank our brilliant panel team for such a thought-provoking discussion on building AI that earns trust before it earns scale. Well, on that thoughtful note, ladies and gentlemen, let's take a short break. Tea and refreshments are available outside, so I request you to please proceed to that side. And also, we'll be starting our next panel by 12. So please be back in 5 minutes, and we'll be starting with our next panel session. So I request everyone to please move towards the tea and refreshments area. Thank you so much. So much. And I request all the guests who are still outside the hall to please come inside and take your seats as soon as possible. I request once again, ladies and gentlemen, please settle down as soon as possible. All right, welcome back once again, ladies and gentlemen, and I would like to take a moment once again to welcome all those who have joined us online on the ETHealthWorld YouTube channel. Thank you so much for joining us and being here with us for this important discussion. So, ladies and gentlemen, so how are we feeling after this short break? Are you all feeling refreshed? Good? Better? All right, I'm not getting any answers, so let's do a quick vibe check once again so that we know that we're good to go for the next panel. All right, so all those who are doing good, can you please raise your right hand like this? Perfect. Now keep it raised for a moment. Now all those who are doing better, can you please raise your left hand as well, like this? Perfect. Now all those who are doing absolutely awesome, can you please join your hands together and give a massive round of applause? Fantastic. Thank you. Thank you so much. Well, now, ladies and gentlemen, we will move towards the next panel discussion, which is titled as The New Economics of Healthcare. Can AI improve the outcomes while reducing the burnout and improving efficiencies? Well, ladies and gentlemen, the moderator of this session is Mr. Saurabh Kumar, Associate Editor, Special Initiatives, The Economic Times. So please give them a huge round of applause as we welcome Mr. Saurabh Kumar. All right, now he's joined by Dr. Shailesh Gaikwad, Professor and Chief of the Neurosciences Center, AIIMS. Let's give them a huge round of applause, ladies and gentlemen. Can we do that louder? Thank you. And now I would like to invite Mr. Bharat Shesha, Managing Director, Philips Indian Subcontinent. And now I would like to welcome Dr. P.M. Uthappa, Group Chief Medical Director, Narayana, Delhi. We were supposed to have one more panel member, Dr. Rajiv Singhal, Managing Director and CEO, Marengo Asia Hospitals, but due to some reason, he didn't make it here. So now I request Mr. Kumar to lead the panel for us.
Thank you.
Thank you so much.
And good afternoon, everyone. The vibe check has been done, so I'm sure everyone's kicking and alive. We'll try to keep this as much vibrant as possible. So before I'm joined by the panelists here, I requested that let's not just give gyan, but let's talk about use cases, because when we talk about AI, mostly how the world is looking at AI, that while we are very good users of AI, we have not been creating good use cases of AI, and that's the most important aspect that I would like to discover in the area of healthcare in the next 40-45 minutes or so that we've been given. So here, and I know that healthcare is under pressure in India. We know the number of patients to doctors, That's huge. There's a difference which needs to be covered. There are rising costs, increasing demand, workforce shortages, and perhaps the most important part, which is to deliver better outcomes. So what we're trying to explore here in the next 45 minutes, gentlemen, is to, can AI help, hospitals scale intelligently, because we know about the difference in terms of number of patients and doctors and hospital care that is available, rather than simply the infrastructure, number of beds and everything. Can it reduce the administrative and cognitive burden on clinicians? Because after all, there is a mind space that exists. You cannot go beyond that. And ultimately, can we use technology to make healthcare, not just efficient, but effective and, of course, sustainable? So with that, let's start. Bharat, probably I'll start with you. And for decades, we've been talking about healthcare systems. They've expanded by adding hospitals, equipment, as I was saying, and people, and that was the yardstick, number of beds and everything. But does AI make that mark a shift from that, from scaling healthcare through infrastructure to scaling through intelligence? And what could that really mean for the healthcare of future of healthcare in India?
Yeah, thank you. And it's a privilege to share the panel with my eminent co-panelists. The future of solving the healthcare access challenge in India is going to be built on 3 elements, and I'll give you some examples of all 3. It is going to be a combination of hardware, software, and AI. And you mentioned about the ratios, and we have a long way to catch up on the ratios as a country. And let me take the example of diagnostic equipment. Today, we have, on a per capita basis, the availability of diagnostic equipment has a significant catch-up to do to get to WHO standards. Now, as a country, can we afford right now to spend billions of dollars in accessing this installing this diagnostic equipment? Probably there are other better uses that we can do if we balance it with intelligent use of software and AI. Use case that currently is already available in India. We have, in Philips, we have a solution called Smart Speed Precise, which is an AI-based solution, which allows for the same hardware to screen an additional 5 to 6 patients a day. Same hardware, better outcome. And there is no compromise on the image quality or the diagnostic capability of such a scan. So that is a great example of how the mix of hardware, software, and AI together collectively are able to produce access to care solutions for many. If you multiply this one machine example that I gave with the hundreds of MRI machines that are installed all over the country, you're talking of millions of people getting access to care. So just investing in hardware or just looking for AI in itself will not solve the healthcare access problem. It has to be a mix of all 3. I'll give one more use case. Stroke is one of the biggest burdens we have from a disease perspective in India. And the golden hour after you have a stroke diagnosis to where there is an intervention is when a patient's difference of life is between dilapidating permanent injury to a recovery possibility. There are solutions available from Philips today that is deployed across the world, and we are working on pilots with Dr. right now in AIIMS, where you can actually transmit the image that you see on a CT to a cath lab while you're transporting the patient to the cath lab. Those few minutes that you're saving, or could be even many minutes because you're putting a patient in a non-urban area to an urban area. All of this is vital in providing better patient outcomes. So it's not just access to care, it's also better outcomes. I think these 2 use cases are, for me, a great example of how intelligent use of AI and using it in the right mix of hardware, software, AI could be transformative to healthcare in India.
Okay. But I'll stay with you for a second. Is it adding to the cost for the patient? Because that's also important. I understand that when you deploy a technology, it's expensive, but eventually, more and more as you research and as you go by, it becomes cheaper. So is that the case in healthcare as well?
So one of the biggest advantages we have in India is scale. And scale is a direct impact on cost. So I think affordability will not be a challenge as long as we scale. If we leave it at pilot, definitely it becomes a challenge. And I think that's where, for me, I always say that the biggest benefit we have in India, if you can use that word, is that if we are able to give scale to technology, and there are millions that are underserved today on healthcare, if we're able to provide an access to them, I think costs will not be an issue. Maybe initially it will take some time, but I think scale will solve the cost problem.
All right. Thank you, Bharat. Dr. Uttapa, I'll come to you, and I had the privilege of speaking to you before coming here, and you told me about how Narayana Health has been using AI in different, verticals within within the hospital. Of course, we'll love to know that, and along with that, I would want to understand, with hundreds of AI solutions vying for attention and competing for to be there in the hospitals. How do you, how do you decide which AI generally deserves investment and which can solve real problems through AI? Because as I told you, as a journalist, I get 100 pitches every day, and 95 of them say we are AI enabled, but all they have done is put on a chatbot probably.
Thank you, Saurabh. Thank you, Philips, and thank you, ETHealth, for organizing this fantastic program. So I would like to start by saying that healthcare AI is not one monolithic entity, okay? It's a series of applications which you deploy at various stages in a patient's journey, or in the back end, in a finance or a SCM or whatever you're thinking about. So when everybody talks about, oh, I have AI, what is it you have, okay? Where have you deployed it and how is it helping you? So one thing we shouldn't do is, just because hospital A has it, you shouldn't have a FOMO and try to have it in your place, okay? So what's more important is, why do you need it? Do you want it or do you need it? What purpose is it serving? Is it trying to drive a clinical efficiency, improve clinical outcome or patient safety, or drive operational efficiency, or improve patient, let's say, experience? What is it trying to serve, okay? So you have to be able to customize where you want to deploy your AI, okay? That's very important. So all these things requires different applications. It's not one AI comes and sorts out your entire gamut of things, okay? So what is the need? What is your pain point? What is the challenge you're trying to address? Okay, that's very important. That's when you can decide, okay, I'm going to deploy my AI in this one. So instead of talking endlessly about this, I will give you some use cases. Before that, I would like to say what we do as a group. So we have around 54 hospitals, out of which 2 are in Cayman and 12 in UK. So that means we are working at scale with high volume. The advantage we have at Narayana Health is we have our own IT company, okay? And we developed our own IT systems, our own hospital information system, radiology information system, lab information system, doctor app, nurses app, patient-facing app. And we also have an intelligence layer called AI analytics called MEDA. So whatever I'm going to tell you now is about what we have done, okay, what we have deployed. And how did you do that and why did we do it? It's because we saw we have certain pain points and we thought, okay, we need to do something here, okay? And we do lakhs of clinic consultations every day, not every day, in a year, okay? That means our doctors are extremely busy. They have 5 to 10 minutes to see a patient, okay? Now, over the last few years, we have digitalized the entire group, so everything is paperless. So multiple feedback we got from our patients is, the doctor is always typing, he's not looking at me, okay? There's no personal touch here. So you must have heard of ambient scribe. A lot of companies providing ambient scribe. So Narayana, we tried to do it ourselves. So we developed our own scribe called MEDA scribe. So what does it do? The moment you come in, the doctor gets to see on his screen, this is AI again, a summarization of his previous visit. So he's already has some idea about what's happening. Okay, that's helping him. Okay, he doesn't have to go through individual clicks and find out what has happened to the patient. There's already reckoner. He clicks on the consultation and start talking to him normally. Like, hi Saurabh, how are you? Any new issues with you? How is your tummy, or whatever it is, complaints you have. How is your breathing? But the thing is, he has to talk. He has to say, oh, your pulse is 72, your BP is so much, your tummy is fine, you have some swelling in your legs. I'm going to see you in a couple of weeks' time or 2 weeks' time. These are the medications I'm going to start you on. Now, the system is listening to you all the time, okay? And there's also another system running, which is patient safety, one in pharma, okay? Here, when the doctor prescribes, it's alerting the doctor about duplication of medication, about interactions of medication, about reducing the polypharmacy. That is called medicine reconciliation. So you've seen ambient scribe working in the background. So this is called CDSS, okay? Clinical Decision Support System. We also have another system nudging the doctor. Could this be the diagnosis? Do you want to do this test? It's not forcing him, it's just helping him there, augmenting clinical care, okay? Helping him make decisions. So once the decision is done, the doctor still has to validate that. So doctor in the loop, human in the loop. Okay, by the time the patient gets up, the summary is ready, he validates it and gives it to you. So the two case scenarios here, use cases. The patient goes to have some blood tests. Almost all our hospitals are we have automated system. So 70% of the blood tests you get are normal. So it's a lot of time for the doctors to validate that. So it's automatically validated. So that reduces TAT time. Our pain point was TAT time there. Our pain point was patient satisfaction and the volume of patients. And our pain point was patient safety. So we address these things. So in the inpatient setting, there are a lot of things I'm going to, in view of the time, I'm going to focus on the main important things. Let's say a patient has been admitted for a surgery, has been in ICU for a couple of days. When it comes to discharge, what is the one thing? There are many things which stops the patient going on time. The one thing that actually stops the patient going on time is your discharge summary. Okay, that has to be really nice. You know, when you go out, when the patient sees this, it should be written in such a way which is jargon-free, and he should understand what has happened rather than being in complete medical terminology. So we have something called auto-summarization. Okay, one click of the button, it kind of auto-summarizes and helps the doctor, and he validates that. And then one of the other most important thing where we deploy is we do 10,000 plus MRIs and X-rays, CT scans a month, and 15,000, 20,000 chest X-rays. Okay, and chest X-rays TAT is too long for us because its volume is so high. The doctors are more focused on reporting a CT scan and MRI. So chest X-ray, we are developing our own system where we want that by the time the patient unbuttons his shirt, the report is ready. That's what we are developing. It's a beta testing. One last thing which is we are very passionate about is a lot of times a malignancy is reported, okay, or a malignancy is detected in a blood test, or it's seen in histology. Most of the time, it's seen by doctors. So we have a bot which scores which goes through all the reports and pulls out the reports, maps it to the doctor, and also tells us which patient has been seen and which patient has not been seen. So that's our second layer of a sieve to catch patients who are not seen, especially malignancy, kidney failure, heart failure, and we capture them, we make sure somebody gives them a call and gets them back. So as I said, your AI deployment should depend on your need.
Got it.
Customize it, yes. And it should be in the place where there's a pain point or you have challenges.
Right. Yeah. And what I like about what you said is that there is a doctor in the loop, which is most important part because I was talking to Dr. Velumani. We were on stage and some time back, and he said that AI is very good. It gives you it tells you half the truth. The problem is which half is correct, you don't know. That's the problem. So it's good that it nudges, but then there is a doctor in the loop. So Dr. Gaikwad, I'll come to you. And we heard Dr. Uthappa put in those layers of AI. You operate in a completely different environment, pressure, and kind of expectations also. So from clinical perspectives, Where do you see the greatest opportunity for AI, in augmenting doctors genuinely rather than just automating tasks? Because your kind of pressure is completely different, I would believe.
First of all, thank you, Philips India, to have me here, and it's a great honor to be amongst the co-panelists. So I think my area is very different. I'm a neuroradiologist as well as an interventional neuroradiologist. So my jobs entails me to perform the procedures like mechanical thrombectomy, treating the aneurysms, the AVMs, the dural AV fistulas, doing the diagnostic work, be it CT, MR, DSA, right? Chest X-ray, for example. So talking to the very specific chest X-ray, suppose there are almost 800 to 1,000 chest X-rays that are available to me for reporting on day-to-day basis. It's going to burn me out if we start reporting all of them. So here I think the role of AI comes into picture, right? You can integrate the AI for a reporting thing using all those GPT-4 reporting algorithms. It will at least reduce the number of scans that will be delivered eventually to the radiologists for the reporting purposes. For example, out of 800, if the routine, the normal ones, they are taken care of by using the AI tool. The rest critical, very difficult to diagnose. I think the radiologists can focus on those. So it will help with scheduling. At the same time, it will reduce the burden on the radiologists. And at the same time, it will improve the efficiency of the reporting guy. So this is the diagnostic part, but coming to the main area where I work in regularly, that is the stroke, for example. Some neurologically acute challenges we face every day. So it may be in the form of acute stroke, which may be ischemic, which may be hemorrhagic. That may be a case of aneurysm, which would have ruptured or it has not ruptured. Then there are brain tumors, right? So brain tumors, there is a role of AI, and the other last thing is the fractures of the brain, the cervical spine. So here I think the role of AI is very important, and now it has proven beyond doubt that the efficiency of the AI-based tool has gone up to almost 88 to 95% of the time. So it has improved the efficiency at the same time. Now coming specifically to the acute stroke, India, the huge population, humongous burden of acute stroke. Annually we see 1.8 million stroke. 4 to 5% only receives IV thrombolysis. And according to our own trial, we published a trial, grassroots trial in India, and AIMS took a lead role here. We could manage to treat only 0.7% of the stroke globally, across India. So what we realized, there are some challenges, like bringing the patient to the comprehensive stroke center from the spoke, or the areas like district hospital and the primary to a comprehensive stroke. But if you have something called a hub and spoke model, here you can reduce the time taken by the patient to reach to a comprehensive stroke center. And by using a cloud-based software like what Philips has launched, like Lab, I think you can always refer the patient from the district hospital straight to the hub. And by doing this, it is improving the efficiency, reducing all those wastages in the transport and other thing, and patient going from one center to the other center, especially to centers which are not endo ready. So by hub and spoke model, it can identify the patient, whether it's a large stroke or it is a minor stroke, whether it's reach a patient to go straight away to the hub so that it can bypass the other centers like district or secondary stroke centers. So we can call it a mother and ship, or you can work on a model called drip and ship, those kind of a thing. The other thing where the AI can help us out is the mobile stroke unit. It can be installed and integrated with the mobile stroke unit, especially with the CT scanner. We call it CT on a wheels, right? So we can say that. So here they have the capability to image the brain. At the same time, the vascular imaging is also done. Like CT angiography, you can get a perfusion-based study. The whole idea is to know whether it's a large vessel occlusion, which requires straight away taking the patient to the hub, or it is a small vessel occlusion where IV thrombolysis is good enough. So the patient need not be shifted to a hub, right? It can be treated right at the primary or a secondary stroke center and managed there. So it will reduce the burden on the hub. So that is one area where I think the AI-based tool is very, very handy. The other thing is, like, I'm in a hub, I know that the patient is en route, I get alerted. The entire team which is managing a stroke, it gets alerted. So we are on the run, we rush to the hospital, it reduces our transport time, we are available on site, and the patient can be straight away shifted to the angio lab. The CT is already done, CT angiogram is also done. We straight away push the patient into the angio lab, where when the team starts from the femoral artery puncture, go to the target artery, do a mechanical thrombectomy, remove the clot, and by reducing the, I think, the door to needle time, groin to the target time, you are improving the outcome eventually in the patient. So I think that's a tremendous impact, I think, of those AI-based tools. And of course, in hemorrhage, it can accurately diagnose hemorrhage. Even if it is a small hemorrhage, it can clearly diagnose hemorrhage very, very correctly. Then there is another thing called rapid AI. You can do the stroke, I think, the aspect scoring, whether it's above 6 aspect or below 6. The outcome depends upon what is the baseline aspect and what is the baseline MRS. So here the AI has taken a good impact.
Some of the things that you talked about sound so utopian when you say that, some patients on the way and the doctors get alerted. And I mean, these sound very utopian, but of course, and we would want to believe that AI would do these things because, as you said, the number is abysmally low of how many people actually get help during stroke. That's very poor numbers. We really need to work. Dr. Gaikwad, staying with you for just another moment, and with AI coming in, so for clinicians especially, what are the loads which we think has gone down, but actually has the stress has increased much more? You said about, that, obviously you get all those reports, scan, and then they give you a summary, but there must be some things which the pressure on you has gone up more in terms of after AI has kicked in.
The pressure has gone up. I think the expectation has gone up because if the AI has come, there's a general belief that there is a overall improvement in terms of improved efficiency, the outcome has to be good, and the main problem with the AI is that it is not yet medico-legally accepted, and someone has to authorize it, approve it, before it can be signed out. So medico-legally, AI is still not yet accepted, and that really increases the stress on the guy who's using AI-based tool for day-to-day reporting of the use scans that are improving the efficiency, but at the same time, if the AI goes wrong, then who is going to be responsible? So that's something which is adding on the stress to my mind. And of course, the specificity, right? For example, it's not 100% yet. But has it improved over the human reporting? I will say definitely it's better than the human reporting.
Right.
That's one thing.
Of course. Yes, of course. The legality of decision making by AI is something which is being debated across the world, across sectors. Banking is another example where you cannot let AI take decisions, financial decisions, because those are affecting the person. So you can have other places where you can allow, but obviously not in medical sciences as of now, I would believe. But yes, of course, there would be improvement. Bharat, coming to you, so you heard, and healthcare leaders are under pressure to deliver better outcomes, as Dr. Gaikwad also say. But with limited resources and while addressing, all these clinical burnouts, has AI reached a point where you think that it can fundamentally change healthcare economics, which we were talking about, by enabling sustainable models for care, which we spoke about briefly? And if there are particular lessons for India that you have, which you can share with us?
Sure. I think it is already altering in many places the fundamental economics of healthcare, particularly in the West, where you have a severe shortage of radiologists, of technicians, of doctors. where access to care is not about affordability, but it's really about access. And I'll give you a good example. There is a country in the West where today there is a possibility for an MRI to be transported in a truck to rural parts of that country, where the scan happens remote, so even the truck driver can ensure that the scan is done because there is a remote connection, and the radiologist or the specialist or the technician is sitting somewhere in a city guiding the truck driver how to do the scan. So this then does two things for economics. One, it gives you scale because the same machine is going around broader areas. Two, it gives you access because the patient is not coming to the hospital, you're taking healthcare to the patient. And three, it ensures that your costs from a healthcare provider perspective is also to an extent minimized because you're not having the radiologist traveling around everywhere and doing this. So there are examples like this. Dr. Gaikwad talked about the stroke example. The moment you're able to bring patients to your cath lab at the right time, then the ability for you to scale that care without adding 30 cath labs all over the country also changes. So I think there are fundamental differences to economics is happening. And for India, the biggest lesson that we are taking on board and we should continue to embody is, as Dr. Banwal said this morning, unless there is trust, we cannot scale. And we have the benefit of, and even the Future Health Index, even last year and this year, continues to say that we have the most receptive audience to AI in healthcare in the world. And it's not by a small ratio. There is 20 percentage points difference between acceptability of AI in India versus the world average. So I think we have all the foundations. Economics is a function of scale. I don't think anymore it is going to matter if we have stable and consistent demand that the government and our healthcare providers can provide. So I'm very optimistic that economics will change, AI will transform healthcare. And the last thing I want to say here is, in India, we have three problems that we need to address at the same time. The three A's, as I call it, right? One is access, second is affordability, and the third is awareness. And all three need to be solved, and I think it is very important to see how AI can transform and solve all these three things while keeping what you said, economics, which is affordability, in play.
All right. So there is another part which I'm really intrigued, and I'll ask you this question, is that yes, you talked about scale solving the problem of sustainability and affordability. There's also a very good concept, an idea called innovation, which is also happening at the, there is a guy I know, he's been written about, who has created a small device which is again portable, as you said, which can go around and do chest scans and all, and it's very affordable. Are you also looking at that way? Because if both things work simultaneously, I think in what we heard, if both trains are moving in opposite directions, the time reduces.
Yeah. No, absolutely. And I think what is important to take out from that lesson of Cure AI is you bring care to the patient. Scale comes when you're able to take the care or access to care to the patient. Because let's take a picture of rural India. There are people who are dependent on working every day for their wages. If you're asking that person, because he has a little bit of a cough, to come to a city which is 2 hours away to get that test done as a first line of diagnosis, that person is judging between losing 2 days' wages to taking care of my cough. And unfortunately, today the judgment is made, I don't want to lose 2 days of wages. So when you are bringing care to the patient or the potential issue that may be there, you're immediately multiplying scale. Because that intuitive guess or intuitive choice that you make between going to saving your wages is no longer relevant. And I think that is where the scale will be unlocked. And we have, as Philips, a couple of innovations that we are piloting right now with institutions like AIIMS, which exactly have this philosophy. Let's take care to the patient, or let's make sure that care is dispersed to the patient. And the key ingredient of doing this is AI, because AI is the one that can make sure that you do this in a safe, patient-focused, and affordable manner.
All right. Okay. All right. Dr. Uthappa, I think good time to segue. And and could AI, if in your opinion, enable hospitals to identify deterioration or diseases risk much earlier? Because at times we've seen that patients have been diagnosed with something, but it takes a lot of time till the time they are given some medical aid. So what needs to change really in care delivery for that potential to translate into better patient outcomes?
Thank you, sir. Saurabh, excellent question. The doctors love this. So I think that's one area where AI has the most potential. Okay, if you look at what's happening now, most of the way the doctors treat patients is reactive once in the hospital. Okay, the patient deteriorates, some numbers change. Okay, you go and have some blood tests, have some imaging, and the patient gets treated. Okay, but imagine a situation where you can predict something is going to happen in 6 hours, 12 hours, 24 hours, and you can take some affirmative action on that. Okay, that's where we are coming from. So, as I always say, your AI application should be depending on what's bothering you. So we have 1,500 ICU beds in the country. Okay, and we are very keen to make sure that our standard mortality rate is below what's acceptable. So we try really hard to bring that down. So one area we have looked at is reducing cardiac arrest and predicting it. Okay, so how do you do that? So there are some logic and algorithms built on it. So the doctors get alerts every couple of hours. Okay, that has to be very careful. You have to be very careful with that because you don't want to alert them every hour. Remember, we have 1,500. The doctor will be very fatigued and is going to turn off all the alarms. Okay, so
smartwatch.
Yeah, like a smartwatch. So remember the responsible AI. One of the things of responsible AI is explainability. So when you have an alert saying that this patient is going to deteriorate in so many hours, when you click on that thing, it should tell you what's driving that deterioration. Okay, is it low saturations or lower oxygen or hypovolemia, sepsis, or some increased heart rate, so that the doctor or whoever is acknowledged that can actually go and work on it and prevent that from happening. So this is a preemptive strike before something really bad happens. We are also working on, this is in the beta testing phase, on a renal bot. It's a renal, for people who are not doctors here, it's kidneys. 20% of your ER admissions anywhere, okay, has some degree of kidney dysfunction. So 50 to 75% of the patients in ICU have a kidney dysfunction. Okay, and around 40% of patients in inpatients have kidney dysfunction. That's a huge burden of kidney issues. And there's proven, it's proven that if these patients are intervened early and referred to a nephrologist, their outcomes are much better. So this is our problem statement. So we developed a renal bot, which the moment a patient gets admitted, looks at various parameters and tells you the chances of this patient deteriorating with kidney failure in the next 12 hours is 20%, 18%, and whatnot. So if the patient goes for a surgery, obviously it's a high risk thing. Any surgery can affect the kidney function. It'll show you, and it'll show you what are the parameters that's leading to this. So you can intervene and stop that course happening, okay, from happening. So we also have a few more which are still in the beta stage and of testing and whatnot. So the point, as you asked, is predictions on its own might not affect outcomes. So how do you intervene? Okay, so your predictive risk predictors should be part of your workflow. Okay, it should sit in the workflow. So if a number pops up saying that the chance of this patient deteriorating is so many %, so who sees that? Is it a nurse? Is it a doctor? Or who's going to acknowledge that? And what's going to happen that? Only then you will know that because there is a prediction, you intervened and the outcome has been different. Okay, so that thing has to be the workflow. It has to be embedded in the workflow. Okay, so your predictions without intervention is just a fancy number. So it should have a nice intervention. Otherwise, you're just showing some fancy
numbers. Do we have any stat on that how much this has worked, or accuracy of?
Say that again.
Do we have any stat on this in terms of accuracy of this method that you just talked about?
Okay. All the things I'm saying is all developed in-house. Okay, we are not commercializing it. So
just for an understanding,
at the moment it's around hitting around 80-90%, which is still good for us because 4 months ago we didn't have that. 4 months ago it was a doctor physically going through all these things and figuring it out. Okay, everything looks fine, I'm okay. But now we have these predictors. We have screens everywhere. The doctor is seeing it on a regular basis, and it is telling you what is happening. Okay, so at the moment, when we publish it, I'll let you know. I can't tell you about each one because some of them are quite sensitive.
Of course.
But they're looking good, and it's basically saving patients.
Yeah, no, definitely. That's the idea, and it should be promising enough to be pursued at least. And if that's the confidence level at which you're working, I mean, that's pretty good enough.
I mean, you have to understand that these are all in-house applications we're developing. The models are developed in-house. The patients are in-house. So as and when we do it, we're tweaking it all the time. And the doctor is always there in the loop because, in fact, it's our ICU doctors who is driving it. So when you let the doctors drive it and support them, there is ownership and accountability, and they're going to use it. And if I go and plonk it on them, they're not going to use it.
Of course, of course. Dr. Gaikwad, I'll come to you. You heard Dr. Uthappa also saying about these in-house built, of course, promising sort of ways to diagnose, predict, and everything. Do you trust these methods? And if so, where is the greatest potential for AI to improve, your clinical decisions rather than just speed? And where do you still think that human-led decision making is still required and will be required probably in coming years or decades or so?
So from the practical point of view, I see, for example, in decision-making process, like say there is an aneurysm which is detected incidentally on routine imaging, and if you use an AI, you want to know what is the probability that's going to rupture very soon. So in this area, if AI can help us out, evaluate the aneurysm, show any signs of impending rupture, the treatment algorithm will change altogether differently. So here I think AI can help us out. The other area is studying the flow dynamics of the aneurysm. If I'm supposed to treat this patient, what kind of device I have to use it, which will be the appropriate sizing, the length, diameters, the braiding of the devices, and how the dynamics in comparison to the inflow as well as the outflow zone is going to behave before I deploy. Means virtually, should I have an analysis of this aneurysm, how it's going to behave if I'm going to treat it? So here I think that's one area where I do flow dynamics of the aneurysm can be done. I think that's one thing. The other thing is, I think certain areas of the brain or the spine, they are difficult to image with the routine imaging. For example, the CT, the MR. What happens in the areas which are in the vicinity of the dense bone? Here I think beam hardening artifact obscures those areas. So here a human being may make errors by missing out the lesions, right, altogether. So if you can use this DLRA, like say diffuse learning reconstruction algorithm, which are largely AI-based tools, here they can reduce the slice thickness from 5 to 1 millimeter by using improving on the iterative reconstruction module. So the lesions which were hidden because of the artifact, if it removes the artifact by reducing the slice thickness, it can improve the diagnostic accuracy of the diagnostic radiologist. So I think here, we should work on it. Then India should have a software which is similar to Rapid AI. And we are already working on it. Then there is a condition called drug refractory epilepsy. Here there are several spectrum which can cause drug refractory epilepsy. Here if we can have a software based on AI algorithm which can improve the diagnostic accuracy, I think in these areas, I think we should try and work it out and use the AI-based tools here.
Okay. Thank you so much. Enough food for thought for people here who are on the path of innovation. I think to a certain extent, I was talking to Dr. Uthappa before this, that the concept of digital twin probably here can come in and work. I'm not sure. I'm not a tech guy, but as I understand that if what Dr. Gaikwad is alluding to, that can be solved. So gentlemen, we have another 5-6 minutes on the clock. I'd like to look around the room and see if anyone has any questions, if you guys are okay with that. Anyone, any question for the gentleman here? Or we have covered enough of AI and we want to have another cup of coffee? Which one is the, any question? No hands? All right. All right, I think we have a question here. Do we have mics here, or I can pass on my mic to you?
I can reach out to my voice. Me?
Please go ahead, sir.
First, I'm Anjan Bose. I'm ex-Philips. I was Bharat's predecessor some years back, and we didn't have enough of AI for sure. I think we are going to see a lot of AI. That's my personal impression. Discuss a lot of AI. Saurabhji, first of all, excellent moderation. I think it was a very enriching session. I just want to say this from my heart. I've been in industry, so various panels, so excellent discussion. I have one question. The human aspect of healthcare. I mean, healthcare in Philips, we deal with multi-sectors. At the end of the value chain, in any other business, there is an inanimate object coming out, a piece of an automobile or a car, or a mobile phone or a computer. Here is a unique sector where at the end of the value chain, there is a living human being in agony, surrounded by emotional close relatives and friends. And this aspect is a very important aspect. You know it from being a senior journalist. So I'm just wondering how all of us will cope up with this factor of not losing the human touch while also doing justice to our own organizations in terms of the business outcomes. If I may sum up, what I'm trying to say is balancing out, the care part with the balance sheet. How does Bharat or anyone from Narayana or Dr. Gaikwad, you have a responsibility towards your institutions, you have a responsibility to the patients. So balancing the balance sheet with patient care. I know it's a big question for us, but I just wanted to raise it.
Thank you so much. I think what, Dr. Uthra, would you like to take it? I think it works both ways. I mean, you are increasing efficiency that's at the back end, it's taking care of the bottom lines and top lines of your company.
As doctors, I don't think you should submit your clinical judgment to AI. Okay, AI is here to help you. It's just sitting on your shoulder and nudging you, alerting you, directing you, and augmenting your decision-making skills. Things like counseling, touch, palpation, emotions, empathy, consent should rest in the realm of humans or doctors. Okay, that should not be taken away. Okay, and that's where you have this human in the loop. At this point in time, nowhere in the world says that you can report an AI report and say it's done. No, the doctor has to validate that, and that we have to preserve and we have to fight for it, because in future it might change. I don't know, in 10 years it'll be so good you might not require a human in the loop. But me being a clinician, I would like to be part of it and AI helping me.
All right. Any more questions, anyone? Any more questions? No? All right, then I think we are the fag, and so we'll kind of close this. And of course, I mean, for this sector, as you said, I think at least in my opinion, in the foreseeable future, I don't see the human going out ever, because it's the human touch that the confidence that I as a patient always seen in the doctor who's standing there or the clinician or the, anyone around me at that point in time. If I don't see them, if I only see machines, I'll be scared, honestly. So, AI will be working at the back end, but human will be in the loop. And as I said, I alluded to, there are sectors where you need human in the loop always. Banking, of course, and healthcare, I don't think it's going away. So thank you so much, everyone. Thank you, audience. You've been fantastic. And thank you, panelists, for such an engaging conversations. A round of applause for everyone. Thank you.
Thank you, Mr. Kumar, and a big thanks to our esteemed panel members for such a grounded, honest look at the economics behind the promise of AI. Real proof that innovation and human well-being don't have to be at odds. So now, ladies and gentlemen, please help me invite, with a big round of applause, Ms. Ozlem Fidansi, Chief of International Regions, Philips, to felicitate our esteemed panel members with a planter. Can we make a round of applause, ladies and gentlemen, at this beautiful moment? Thank you so much once again. Ladies and gentlemen, as we near the end of a truly enriching morning, it's time for our closing remarks. I invite Mr. Arvind Vaishnav, Head of Philips Innovation Campus, to share his final thoughts and takeaways from today's summit. So ladies and gentlemen, please join our hands together once again, and let's welcome Mr. Arvind Vaishnav.
Maybe I'll start here. And then, well, good afternoon, everyone. It's always very difficult to have the closing remark when you get so many beautiful and amazing insights. That's, I think, is the toughest part. But as we come close to the end of the day, I want to begin by thanking Dr. Sunil Baranwal, the CEO of NHA. He was here, shared the right tone for this summit, and shared the vision of digital healthcare in India. I also want to thank Ozlem for being here. Really honored for you unveiled the Future Health Index 2026 for Philips. It's an amazing document. It very concisely captures the global and the Indian perspective of healthcare. What are the opportunities and challenges? I think it is becoming a very foundational report or a document for anything that as a Philips we want to do in solving the healthcare challenges. Last but not the least, I want to thank you, our esteemed panelists, for not just talking about what can technology achieve, but also showing their optimism that India is a great place and can really transform the healthcare if the right tools and the technologies such as AI is available to us. As I said, it's very difficult, but I had 4 key points that I think we must take away from this. The first and the foremost is AI is already creating an impact. Now, so what more? And I think one theme that went through all the thing is, how do we implement it? How do we deploy it responsibly so that it makes an impact to the clinicians and physicians? I think that's one of the most profound things that I heard. The focus should not be on technology. The focus should be on patients and clinicians. And Dr. Panigrahi, you said very beautifully that everything else we do You must understand the experience that the patient should have. You also talked about how can AI should be deployed at a grassroots level as we built it up, and that's the way to go where we will create an impact from the human standpoint. So I think those were fantastic remarks. The second and the most strongest takeaway that I had probably was the trust that needs to be created before we scale. And the trust on AI is just not come if we say, yeah, I have a good AI model. So the first panelist, and Dr. Kritika was very particular about it, when she made that the trust should be earned on the AI model. What she measures herself and holds it, if I can give this AI tool to my staff and let them use that AI without my supervision. And I think that's her measure of trust which comes in. So that was an excellent remark. I also feel that as a technologist, as people from research, as people from medical delivery fraternity, all of us need to do a few things, which also I captured through the framework. Build models on the Indian data set. I think Dr. Sunil also highlighted that very, very clearly, and he also talked about how the framework of SAHI is actually creating that platform where more companies can come together and leverage that platform to build more AI models and the right governance which comes around it. So I think creating the right solutions built on data sets, more and more validation needs to be done. I think a very apt remark was what we develop, AI models in lab, may face a very different perspective when you deploy it into a real-time situation. So I think people here who work with me in Philips and otherwise who are technologies passionate about AI, I think that was a very, very fundamental remark. I think Doctor also expressed very clearly that AI would scale and will find the right adoption only if AI become a pull AI, not a push AI. So it's a very, very clear message for all of us. And I think I mentioned already to you that when you are deploying at a grassroots level, as you said, Dr. Panigrahi, then that's the right measure that you are able to scale it with more confidence. The third point that I talked about, or I took away from the sessions were, the real promise of AI lies in augmenting the clinicians, augmenting the physicians to do the right things for the patients. We can't just simply say that I have the best AI model and deploy it, right? AI can do, at best, is it can remove the friction between the clinicians and the patients. It can augment them, it can amplify the work which they are doing to help their patients. But there is no way they will be out of the loop. AI cannot take the empathy or the trust or the bond which is there between the patients and the physicians. The trust has to be, yes, I have something and it's getting amplified by a use of AI, and that's where the human element, I think in the previous panel it was very, very clear that the human element is not going to go away, at least in healthcare, even if we deploy the AI tools. Last and final one, I think we all know the India healthcare system, very unique. Lot of different perspective. If you look from a disease pattern perspective, if you look at the youngest population perspective, if you look at from any dimension, Indian healthcare system is very, very unique. And so when you look at these things, India is a great place where AI can be deployed, it can be scaled, it has a fastest growing digital infrastructure, so it's the right time. I think Professor Gaikwad in his speech talked about one of a very unique model. We said hub and spoke model we have been using about, but how AI can actually further amplify it. And that's the kind of example that was quoted there. So I think India has been doing a lot of things, but I think the scale of doing and the efficiency of doing that with AI will actually increase multifold if we do that. My takeaway from the previous panel was India has a potential not just to adopt AI, from a healthcare innovation standpoint, but actually set a global blueprint for equitable AI-enabled healthcare. As we leave from here, I really hope that we do not only talk about algorithms, platforms, training models, but we talk about patients whose life we are impacting collectively and giving more time to the clinicians. With that, thank you very much. I think it was really a pleasure to listening to all the great speakers here, as well as the clinicians with whom we will jointly work together and bring the vision of AI to really impact people from Philips' perspective. Thank you very much.
Thank you so much, Mr. Vaishnav, for bringing today's discussion full circle from policy to trust to economics and finally to innovation itself. Well, ladies and gentlemen, before we head to lunch, I would once again like to draw your attention to the AI showcase around you to scan the QR code on the standees for the Future Health Index 2026 India report, if you haven't already. And please take these last few minutes to explore and speak to the teams present here. Well, now, ladies and gentlemen, I would like to express what a morning, what a brilliant morning it has been. We have covered incredible grounds today, and I hope you're leaving as energized as I am. Well, give yourself a big round of applause, ladies and gentlemen. Every single one of you in this room is a part of shaping healthcare. A huge thanks to the Philips and Economic Times ETHealthWorld for bringing us all together, to our incredible speakers and panelists, and to everyone turning it on to the ETHealthWorld YouTube channel. Well, this isn't the end of the conversation, it's just the beginning. So let's turn today's ideas into tomorrow's impact. So lunch is now served, ladies and gentlemen. Please move towards the lunch area and use this as a chance to engage to each other. Thank you so much, ladies and gentlemen. Once again, this is your host, Dr. Azra Khan, and I wish you a great day ahead. Thank you so much.